Hello to everyone. Am I audible, visible? If yes, we'll start the session. Good evening, good evening. Good evening to everyone. I hope you can hear me. So let's start. Please join in. Chalo. So we're starting the class. Sorry for the delay. Starting the class. Sorry for the delay. So how are you all? I hope you are doing good, because today we are doing our remaining part of the class, which is basically related to our neurology. Then we'll do the cardio and endo and all the other stuff. Okay, so please join in. Hello to everyone. Dr. Abigail, Twinkle, Nandini, Risha, RS, Gifty, Maria, Osh Medicos, Sagarika, Uma, Anju, Prajwal. Hello to everyone. Thank you for coming. It is for every PE exam. Okay, Dr. Morima. Okay, yes, it will cover all major topics in the medicine also. So you can attend it, you can study it. It is not going to disappoint you at all. So this is sufficient for most of the exam. You can do it. See, everything is covered here. You can do it and you can study with me. Okay, chalo. So let's continue and let's do it. Okay. So we'll continue with the topic of the stroke. So what is stroke is? So stroke is basically non-convulsive. Convulsions are a part of seizure disorder. So it's a non-convulsive, first question, it's a non-convulsive focal neurological deficit more than 24 hours. So it should be more than 24 hours. It could be, okay. How are you, Dr. Monisha? Okay. Hello to everyone from Delhi. Okay. So all parts of country, India is one nation. Okay. So we are all, yes, going to be good doctors and help all Indian patients, north, south, east, west, no discrimination. Reason, at the end we are doctors and we are here to serve people, not based on their caste, color, creed, nationality, or even state, language, nothing. We should be just treating the patients. Okay. So let's continue. First question. So what is it? It is basically sensory, can be motor, can be autonomic, even cognitive. That is, dementias can also be seen. So even cognitive. Okay. Now, if less than 24 hours, it is called as transient ischemic attack. So here the person show recovery and we use ABCD2 score. This was your last session exam question. What score we use if a patient has a TIA? ABCD2 score. What is ABCD? Yeah, I'll give for NEET PD also, don't worry. Okay, so just study with me, we'll get all the important questions. So what is the ABCD2? It is A for age, more than 60 years. B is our blood pressure more than 140/90, that is hypertensive. C is for clinical feature, like first, what is the feature? If there's a speech impediment, it is 1 score. If it is unilateral body weakness, that is your hemiparesis, we give the score of 2. And D is duration, less than 1 hour, more than 1 hour. If less than 1 hour, we give a score of 1. If more than 1 hour, 60 minutes, it is given a score of 2. And last D is diabetes. This is called as ABCD2 score. Yeah. See, today we are not going to finish the medicine because obviously time is less and we have to cover lots of topic. So I'll take one last session of the medicine in which we'll cover everything. Okay. Most likely we'll take it tomorrow and then we'll do the physiology after the medicine is done. So don't worry, we'll cover and we'll finish everything. That is my promise. Okay. So now, what are types of stroke? There are two types of stroke: ischemic stroke, which is 75%, and hemorrhagic is 25%. Hemorrhagic, basically, if it's a young person, it is trauma. If old person, most likely hypertension. Young is trauma, old hypertension. And most common side of hypertensive bleed is putamen, MCQ, putamen. Ischemic is most common and it is due to thromboembolism, and most common is embolic, more common. Embolic, most common. So most common cause is emboli originating from any part of body. Most common vessel involved in the stroke is middle cerebral artery, striate branches which supply the internal capsule, also called the Charcot artery of cerebral hemorrhage. So that's why it causes unilateral, paralysis, opposite side. So what are the findings of UMN lesion? So these are UMN PT lesion. First, we see clasp knife spasticity. The hand is clasped like this. If you try to move, you find a resistance. So that is called as what? Clasp knife phenomena. So like this is the phenomena. So this is clasp knife. It is not smooth. It is higher resistance in the beginning, then it can disappear. It's called as what? Clasp knife phenomena. Then there is also spastic gait, where the patient cannot lift one side of the body, so drag the body in a circular arc called spastic or circumduction gait. Then there is the contralateral spastic paralysis. Okay. Also there is increased reflexes, increase DTR. So reflexes are increased. Okay. Also Babinski's is positive, which is basically positive for our PT lesion. So what is this positive for? It is PT lesion, we get Babinski's sign positive. So what is the finding here? PT lesion. So I'll just remove it. So right here it is PT lesion. Now what is Babinski's sign? Basically there's a dorsiflexion of great toe and fanning of other fingers when you stroke the lateral margin of the thigh. So this is called as what? So when you stroke the sole, the part, so as you stroke around the lateral margin till the second finger you go, the fingers and the great thumb should go up, fingers fan. This is called as positive sign. Let me show you. So we are seeing the Babinski's sign. So have a look. So this is clasp knife phenomena, where the limb behave like a knife which is closed. When you try to open, it is difficult, but then it suddenly springs open. This is called as the which phenomena? This is called as our phenomena of clasp knife. This is the spastic gait, also called circumduction gait. The person rotate the limb. Then this is wasting of the muscle, and even the limb is becoming shorter. It is seen in the case of again element more, that is flaccid paralysis. This is Babinski's sign. So when you stroke the lateral margin of the sole, you see the fingers are going upward and great toe will move up. That is called as dorsiflexion. But the movement is dorsiflexion. This is called as Babinski's sign. So I'll put this photo there so we can use it. So this PDF I will be uploading in the group. You can use it for your revision purposes. Clear? Okay, let's continue. Now, what is the investigation of choice for the stroke, TIA, or even head injury? It is NCCT head, MCQ. MRI is best, but it takes more time. So we'll always go for NCCT. Hello, good evening, good evening. Yeah, so we will always go for what? MRI. Gold standard is cerebral angiography, but again, it will take time. So we'll always go for, so the first investigation is always NCCT. Okay. Now, types of stroke. I told you ischemic or embolic. Thrombotic is basically formation of any kind of, like thrombi in the vessel, can be atherosclerosis of the cerebral vessels, or embolic is most common. I told you due to DVT, atrial fibrillation, infective endocarditis, they all can generate our, emboli which go to the brain. This is embolic one. Okay. Next question, what are the management? So remember management. So next topic is management. So remember for management, remember if ischemic, do not decrease the BP. Do not decrease the BP until unless BP is above 220 by 120. If hemorrhagic stroke, the main aim is to control the BP. So when should you decrease the BP? So remember management. So management, if hemorrhagic, control the BP, we use CCB. Okay, like we can use nicardipine, labetalol, but no thrombolysis. No thrombolysis is done, and target is less than 140. Now, if it is ischemic stroke, what stroke? Ischemic stroke. Yeah, I'll be available just after the class. So I'll upload it just after the class. Okay. Now in ischemic, do not reduce the BP until unless it is above 220 by 120. Okay. If the BP is 180 etc., just conservative management. Okay. Now what is the case? Is thrombolysis. Okay. Thrombolysis is the main treatment. It is best within 3 hours. Okay. Up to 4.5 hours. If more than 4.5 hours, then we give antiplatelet and anticoagulants. Like what we give? We give aspirin, clopidogrel. Okay, these are given in the patient. Plus we can use low molecular weight heparin. So remember, if it is within 4.5 hours, we will prefer to do thrombolysis using ritaplase, streptokinase or alteplase. Alteplase is preferred. Okay, and remember, if you are doing a CT, remember, if you see a darker area, remember we use the terms like hypointense or hypointense. So if it is hemorrhagic, you will see a bright color. Okay, that is in the case of this. And if it is dark, it is ischemic. So remember, if you see black, it is dark, simple. If it is bright, it is hemorrhage. Okay, clear? So CT, MRI finding. Okay, chalo. Yeah, it will work on WPS, don't worry. Okay, so it is WPS. Okay, please use WPS and it will be working perfectly fine in the WPS. Are you clear? So I'll advise you to take WPS. 1 second. Okay, 1 second. Okay, I just regarding the class schedule. Okay, now I told you this already. It is triad branches. This is internal capsule. The internal capsule is supplied. What are the parts? This is the internal capsule. Internal capsule. What is the story about internal capsule is? First is the internal capsule is the one through which pyramidal tract passes. So that's why lesion cause PT lesion. Okay, so PT, what lesion? UMN lesion. Okay, now management I told you already. If hemorrhagic, decrease the BP below 90 by 120, we can use Dipins. Okay, plus labetalol. Do not use nitro drug because they cause an increase in intracranial pressure. So that's the rule. Do not use this. Do not use this. Okay. Then if ischemic, okay, we should not decrease the BP until unless it is more than 220 by 120. If it is less than this, we don't have to worry about that. Next question, can use thrombolytic with alteplase or ritaplase? We can use thrombolytics like alteplase, ritaplase, but best time is within 3 hours up to 4.4. Or the other drug we are using, anti-clotting drugs, anti-platelet like aspirin, clopidogrel. It prevents platelet aggregation. It is again COX inhibitor. It prevents platelet aggregation. Enoxaparin is LMWH, low molecular weight. Abeximab is inhibit the glycoprotein 2B, 3A and prevent the clotting. So these drugs are used in this case. Okay, so this is the story. Now next question. Also we need to correct the lipid profile, sugar level, weight loss if a person is obese, and diet control, physiotherapy. All these are given, but main treatment is we need to make sure that he is given thrombolytic if possible, otherwise that is the story. Okay, chalo. Next question, right? Yeah, good evening, good evening. Now contraindications of thrombolytics. So remember, first is hemorrhagic stroke, we don't use. Age less than 18 years, don't use. Anti-clotting or bleeding disorder, so any clotting bleeding disorder, again we should not use. Hello Pratyusha. And if there's a recent MI or surgery in last 14 days, again don't use thrombolytic. Or if hypertension, BP more than 180 by 110, that's why we need to reduce. So reduce BP before thrombolysis. Okay, and target is 180, 110. Okay, mannitol can be used if there's a raised ICP, it can be used. Okay, chalo. Next question, meningitis. It's an inflammation of meninges. What is the funda? First, if it's a neonate, it is E. coli or gram negative, most common. World is strepto and staph in world. In India it is gram negative like E. coli or proteus. Okay, then if 2 month to 2 year, it is H influenza, it is H influenza. Okay, then after 2 year, meningococcal, that is Neisseria, is more common, which is gram negative. Diplococcus, you will see kidney shape too, plus also rash history is there, also rash is there. So if they are giving a case of rash with gram negative diplococcus which are capsulated, suspect what? Suspect our meningococcal. If it is adults, okay, most likely it's Streptococcus pneumoniae, it is gram positive cocci in chains. In chains. HIV, it is our cryptococcal neoformans. So if HIV suspect cryptococcal meningitis, okay, then our findings are fever, headache, neck rigidity. Okay, that is the main hallmark. If there's a fever with neck rigidity, suspect what? Meningitis. If there is no fever, then it might be, and worse headache, might be subarachnoid hemorrhage. So might be subarachnoid hemorrhage. So are you clear? So that is our main funda. Okay, next question. Also we can see projectile vomiting. These all are signs of what? Meningeal irritation. So they are signs of meningeal irritation. Okay, it's okay, I also got late today. It's okay, Dr. Shanti. Okay, now these are two signs we do. One is Kernick sign. Kernick, in Kernick the knee cannot be extended, that is it is almost painful to stretch it, so that's why it is called as Kernick sign. Remember mnemonic, knee, Kernick knee, you cannot straighten it, that's extension is not possible here. Second is Brudzinski sign. Remember the mnemonic, Zelensky, remember Zelensky? Zelensky is trying to raise head in front of Putin and Putin put his knee into the, you know, like uske पेट में घुटना मारा, knee. So remember when you lift the head, so lift the head. So किसने हसर उठाया? Zelensky ने. So head is lifted, so knee will flex. सही है? So that is the case. Okay, you can skip INI-CT, that is not that important, but yes, if possible, do the PYQs of INI-CT also, but you can ignore them because mainly it's the NEET PG which are more important. Now, if you do fundoscopy, you might get papilloedema. So papilloedema can be seen in fundoscopy. Clear? It is the fundoscopy. So I hope it's clear. Okay. Now next question. We see also high BP but low heart rate. What is it called? It is called as Cushing reflex. What is Cushing reflex? High BP but low heart rate is called as the Cushing reflex. What is it called as? Cushing reflex. Now what is the next finding? It is our, we do lumbar puncture. Okay, so lumbar puncture. In lumbar puncture, what we need to check or see? So in the lumbar puncture, what we are seeing, okay, first is lumbar puncture for CSF examination, antibiotic should be given afterward. We give empirical treatment. So which treatment? Empirical treatment, ceftriaxone and vancomycin. And what? And vancomycin is given. Okay, now if there's a low glucose in the CSF, it could be bacterial, it could be bacterial or fungal. Pyogenic, neutrophils will increase. If tubercular, we will see lymphocyte. If normal glucose and increased lymphocyte, it is virus. Okay, it is virus. And if cobweb with lymphocyte and low glucose, it is TB meningitis. Please remember them. Cobweb, lymphocyte and low glucose is TB. If there is low glucose, and there is neutrophil, then it is pyogenic. Remember that. And if it is what? Normal glucose and lymphocyte, it is virus. Please remember these three, 100% exam question that is asked. Okay, so 100%. Okay, now comes the question, what else do we also do? If it is pneumo or meningococcal, drug of choice is penicillin is the drug of choice. But remember, if responding well, to ceftriaxone, you can continue that. Okay. Then if it is Pseudomonas ceftazidime, okay, or we can give piperacillin plus tazobactam, okay, that is used in pseudomonal infection. Then cryptococcal amphotericin B, liposomal, add the word liposomal. So liposomal. So liposomal amphotericin B plus flucytosine, okay, also used in mucormycosis. Mucormycosis. So mucormycosis. Again, we can use this. So mucormycosis. Next question. Gram-negative ceftriaxone is sufficient. IV steroids. IV steroid. Dexamethasone. Okay. Now it's working well. Okay. Yeah. Next question is not pause. Sometime I pause to check the comments. So that's why sometime it happens. Okay. Chalo. Yeah. Yes. And inflammation and add ATT. So main treatment is ATT, HRZDS. Yeah, we can give ciproflox if the patient is responding. Okay, Dr. Krishna? Okay, chalo. Now we'll discuss motor neuron disease. So first motor neuron disease we discuss is ALS, amyotrophic lateral sclerosis, also called as Lou Gehrig disease. It is UMN plus LMN. Okay, Stephen Hawking had this disease. Stephen Hawking. So, you know, Stephen Hawking had a very good IQ, sensory function, normal bowel bladder control, eye movements are okay, and also normal eye movements. That's why he can see here and there. What is affected is basically asymmetrical bilateral distal muscles are affected. So, can't walk, can't sit. It's a what lesion? It is our UMN lesion. Then there's a bulbar palsy, which now? Bulbar palsy means the nerve which supply the face, tongue, larynx, pharynx. So 7, 9, 10, 11, 12. So 7 to 12 except 8. 8 is auditory. So for hearing. So it's a sensory one. Okay. See, viral again treatment is, if it is, I'll write down. If it is herpes, we give acyclovir. And if it is CMV, gencyclovir. So gencyclovir, acyclovir. So this is the case. So gencyclovir, acyclovir is the case. Okay. Yes. Now next question. Okay. Hemorrhagic is caused by herpes. ये भी क्वेश्चन आ रखा है. Herpes cause hemorrhagic. So अगर एग्जाम में आया hemorrhagic herpes. So what causes hemorrhagic? Answer is herpes is responsible. Okay, clear? Yeah. However, it can be again used in herpes. Okay, herpes we can use other agents also. Okay, yeah. Chal. Next question. Bulbar palsy. So he cannot chew. So difficulty in chewing, swallowing, speech. So this is which feature? This is our features of the bulbar palsy feature. So these are bulbar palsy features. Also difficulty speech, dysarthria. So bulbar palsy show. Difficulty, okay. And it's a flaccid paralysis. It's a flaccid. Spastic paralysis. That's why muscle wasting is there, but not that much. Muscle wasting is there. Babinski's is positive. DTR increase. This is our UMN lesion. So bulbar is a LMN. It's a flaccid paralysis here. It is flaccid. And in the limbs, it is UMN. So that's why it is UMN. Okay. It is UMN. Okay. Clear? Chalo. Now comes the question. What is the pathophysio? There's a SOD gene mutation. So what mutation? SOD, which is superoxide dismutase. It's an antioxidant. So without the SOD, the free radicals will damage motor neurons. What neurons? Motor neurons. Motor. And that causes our mixed pattern of loss, UMN plus LMN. Facial bulbar is UMN pattern, LMN, but limbs are UMN pattern. What are the drugs we use? Supportive treatment, Riluzole. Riluzole is responsible for what? Decrease the glutamate excitotoxicity. So it decreases the glutamate excitotoxicity. Clear? Okay, yes, you can use the detailed lectures, you can use, but you also have to do questions, especially your prof questions, do them together with the theory, add extra point if they are there, it'll be more than sufficient because it cover the main things you need to know as a medical student. Okay, Jay Sanantan? Okay. And other drug we use is Adaravon. Adaravon is basically free radical scavenger. So Adaravon is for free radical scavenger. Okay, plus supportive treatment. That's what Stephen Hawking had. He had a nurse for everything, feeding, taking care of body, and he married that nurse. Then he divorced her. Story. So there's a movie also made on him. Supportive care. Now come the most famous disease. 100% MCQ. What is the name? What is the name? What is the name? It is our what name? It is our Myasthenia gravis. So what the name is? Myasthenia gravis. First, it's a UMN element. It is our LMN lesion. So what lesion? It is our LMN lesion. So flaccid paralysis occurs. So what lesion is there? LMN. So flaccid paralysis. UMN is spastic. So what is Myasthenia gravis? It is LMN. But our what disease? The ALS, Stephen Hawking. It is both upper motor, lower motor. Okay. Now it's an autoimmune condition, both type 2 and type 5 hypersensitivity. But in the exam, go for 2, better answer than 5. Okay, because the autoimmune in which antibody are formed against the ACH receptor. So ACH receptor antibodies are there, plus also MuSK and LRP4. So because of the antibody destroying the receptors and the neuromuscular junction, acetylcholine fail to act. So that is why muscle fail to contract. That causes flaccid paralysis. So causes flaccid paralysis. It is most common in female. So what is it most common in? It is most common in female, that is 20 to 40 year, and elderly male 50 to 70. कैसे याद करेंगे? Indian movie pair. कैसे याद करना है? Indian movie pair. Okay, चलो, thank you very much Dr. Krishna. So Indian movie के अंदर क्या होता है? हीरो remember all, I don't take the name but they are 70 80 year old. 80 भी हो गया आजकल तो, grandfather का भी father. So that is the case. Okay, so they are becoming, yes, very yes, problematic. Okay, just give me a minute. Okay, I just need to reply. There's a ticket query. Okay, I have a class tomorrow, so just let me reply this, then I will come. Just give me a minute. Okay, just 1 minute. Okay. So it's a very hectic schedule. I take class in the day, night I take sessions for you. So it's not easy, but again, there is no other option left for us. We have to work hard and we have to give our best. So let's continue. Okay, now let's continue. Next is, there is also, yes, finding. Earliest finding is earliest. So earliest is bilateral asymmetrical ptosis. So remember, it is bilateral, दोनों side होगा, and asymmetrical है. So bilateral asymmetrical ptosis is there. So what is there? Bilateral and asymmetrical ptosis is the finding. Asymmetrical ptosis, plus also there is our diplopia. It's asymmetrical. Weakness is more in the evening. So remember, as the evening occurs, the acetylcholine is depleted. That's why the weakness is more. Number 2, exertion. When you do any effort, again the exertion will cause decrease in the level. So that's why exertion worsen the condition. Okay, and then the face show snarling face. One side is paralyzed more, so the drooping of the angle of the mouth. Okay, also there's nasolabial crease pointing downward. There is smoothing of forehead, that is the wrinkles disappear. Eyelid is not opening, that is ptosis is there. This is called a snarling face, so called as a snarling face. Okay, so are you clear? So all these are the fundas that we can see, discuss or have. So these are the fundas. Okay. Chalo. Next question, right? What is the Chalo. Next question. If there is a crisis, respiratory muscle paralysis can occur, which can cause respiratory distress, and death can also occur. What is normal? Remember, the sensory system is okay, nerve conduction is okay, deep tendon reflexes are normal. That was the exam question. What condition there is paralysis, flaccid, but normal reflexes and nerve conduction? It is our, yes, which disease? It is our very famous, that is our, yes, myasthenia gravis. Okay, and it starts from the face first, that is the ptosis. Okay, then the investigations of choice. Remember, most specific and most sensitive. So remember, first is, right, most specific is antibody detection, but most sensitive is single fiber EMG. So it is our single fiber EMG is the case. So single fiber EMG. I hope is clear. So which is the most sensitive one? So most sensitive is EMG, but if they say most specific, then your answer changes to antibody detection. Yes, antibody detection. Okay. Next question. Our older tests not used nowadays, but asked in the exam. One was ice pack test. If you apply ice pack on the, yes, affected muscle, the cold temperature inhibit choline esterase. So remember, cold temperature inhibit choline esterase and increase ACH. So the mechanism is cold temperature inhibit acetylcholine esterase, increase ACH. It will increase the ACH, increase the ACH, and as ACH increase, what is going to happen? It causes decreased paralysis. Are you clear? So that's why I will open more, called as our ice pack test, but not very commonly used nowadays. So not use much बोल रहा हूँ, कई बार कर लेते हैं कई हॉस्पिटल्स में, they do apply ice pack test. Yeah. Next is tensilon test. Tensilon test is we give androphonium. Androphonium again causes inhibition of choline esterase, again ACH, and cause decreased paralysis. Now drug of choice is choline esterase inhibitors. Which inhibitors? Choline esterase. Pyrido is the drug of choice. Why? Drug of choice is pyrido. Why? Longer acting. Longer acting. Neostigmine again is short acting and they don't cross blood-brain barrier, so can be used. Okay. Steroids can be used mainly in crisis. Myasthenia crisis, we can use the steroid. Okay. Also, we can remove the antibodies by plasmapheresis, or we can give immunoglobulin, which are antibody against the receptor antibodies. Okay, so that can be done. So steroid, etc., can be done. And what we can do in severe cases, surgery, thymectomy is surgical treatment. Now GBS, very important. GBM. What GBS is? Guillain-Barre syndrome. Again, it's autoimmune type 2 hypersensitivity. Antibodies are formed against gangliocytes. GM antibody, GM1, GD1A, B. So these are antibody against gangliocyte. What do this antibody against gangliocyte do? They are going to, yes, destroy our gangliocytes. As they destroy the gangliocyte GMs, it causes destruction of myelin sheath that cause poor conduction. So that causes poor conduction in the nerves fibers. and it causes polyneuropathy. So it causes demyelinating polyneuropathy. What does that mean? Not one but multiple nerve, multiple fibers are affected. What is it called as? Polyneuropathy. Polyneuropathy is there. Okay. Sarita, practice more question. Okay. As you practice more and more question, it will be very beneficial to you. Okay. So my only request is, if you get an answer wrong, write it somewhere and now make a error logbook. If you make a error logbook, you will remember and you will be able to understand it much better. So that is error logbook. Okay. Now comes the question GIT. So in GIT, what do you have? We have the Campylobacter jejuni. Okay. So it's a GIT infection, but more common is respiratory. Respiratory is most common. GIT is GBS. So there is what infection? Either GIT, Campylobacter jejuni, or respiratory viral is like CMV, EBV, okay, Zika, okay, RSV. These viruses cause infection, then antibodies are formed. These antibodies then destroy our, yes, myelin sheath. Non-viral, we can have mycoplasma, HN, even vaccines can cause GBS. Now, main thing, there's a bilateral, symmetrical, ascending paralysis, also called as Landry's. Also called as Landry's. So that's why first to be lost is ankle jerk. Remember, jerks are absent in GBS but present in myasthenia. Ankle jerk, then knee jerk. So they are lost. Then there is also pain and paresthesia. What is there? Pain and paresthesia is there. So pain and paresthesia. Okay. Then also there is what? Loss of touch, vibration, etc. So you lose the touch, pressure, vibration. There is a sensory loss. So remember, there is a sensory also, motor also. Most common nerve, that is nerve involved, is, should be nerve, most common nerve involved is facial. Clear? Also difficulty standing, walking, okay, and bowel bladder dysfunction. Bowel bladder dysfunction. Then what is the CSF show? Albuminocytological dissociation. What does that mean? Increase proteins but normal cells. Cells are not increased. If cells are also increased, suspect what? If cells are also increased. If cells are also increased, suspect our what? Meningitis. Okay. So that's the case. So increased protein but normal cell count. Okay. Nerve conduction is the main test. So IOC is nerve conduction and antibody obviously. So nerve conduction. What do you see? There's a decreased velocity, increased time, that is latency, decreased amplitude, and also abnormal H reflex. That's a very important question. Abnormal H reflex. H reflex is like a stretch reflex, but it is done during the nerve conduction testing. You activate the sensory nerve and see the muscle contract. That is called as the H reflex. Okay. Treatment is plasmapheresis and immunoglobulins. Okay. And most patient, very good recovery. Within few weeks, the patient is normal. So very good recovery is there. Okay. So thank you, Dr. Kupar. Okay. So very good, yes, recovery occur within few weeks. Okay. So that is the case. Okay. Remember here, we don't need to give any other medication. Most of the time when the antibodies are removed from the body, the person is getting better and better. It takes time for healing, but most person will recover within few weeks. Okay. Now spinal cord syndrome, I am giving the summary. Please remember, Brown-Sequard is hemisection. So there is a loss of the touch on same side, pain, temperature, loss, negative, lost on the opposite side, that is brown sequel. Tabes dorsalis is seen in neurosyphilis. Neurosyphilis. It is loss of the touch, pressure, proprioception. Lower limbs, on the lower limbs, both the side. But pain, temperature is intact, and also there is a what gait? Stomping gait. Next question. Syringomyelia is basically a syrinx in the central canal. Cyst कह लो, syrinx और cyst. ये क्या करती है? Compress the fiber, mainly cause loss of pain. So bilateral loss of pain in the upper limb chest. That is which area? Cape area. इसे बोलते हैं cape ना. मैंने भी क्या पहना? Cap पे देखो. So upper limb and chest called as cape area, and also bilateral spastic paralysis. But remember what is present? Both the side touch is intact. Okay. Remember what disease you lose the touch in the legs, lower limbs? It is tabes dorsalis. What disease you lose the pain, temperature in upper part of body? It is the case. So remember upper limbs, chest, bilateral is our syringomyelia. Lower limb is tabes dorsalis. If right and left, it is the brown sequel. Right, left is brown sequel. Okay. Yeah. So syrinx in central canal. Now comes kids. What is kids? Is subacute combined degeneration of spinal cord, also called Leishman disease or Putnam-Dhana syndrome. Okay. Now what is the story? This is the degeneration of dorsal column which carry touch, and lateral corticospinal which cause the motor effect. So that causes the spastic paralysis. Okay. So the spastic paralysis can also occur. That's why Babinski's is positive. Okay. PT. Mainly due to vitamin B12 deficiency, can be due to E or copper deficiency. There is the paresthesia, sensory loss, mainly lower up more than the upper area. So lower extremities more than upper. Okay. And it is bilateral. It is bilateral. And also there is going to be what? Mainly touch. Mainly touch. Okay. Okay. Then ataxia is there because it's sensory ataxia. Rombuck test will be positive. Then ankle jerk is absent. Memory loss can occur because affect the cognitive function also, and it's a reversible dementia. You can give and correct. Reduced vision, Sandel's scotoma, again because of actually what happens is a demyelination. Because we know vitamin B12 help in the formation of methylmalonyl coenzyme A, which help in myelination. Okay, that's why the demyelination. Then also there is anemia also, and anemia is there, and megaloblastic anemia. Okay, so megaloblastic anemia also occur in this case. Okay, megaloblastic anemia. Next question that we see is there is sphincter disturbance, so that causes bladder bowel, so affect the bladder bowel. And main is Babinski's will be positive because I told you it's PT lesion, plus there is Romberg sign positive, Romberg's. Romberg's. Okay, so Romberg's will be positive in this patient. Are you clear? Fine. So Romberg sign. Now next is treatment is obviously we need to give what? Treatment is B12. Very common in vegetarians. So we give the Next is MRI. In MRI, there is a bilateral symmetric signal high intensity that is within the dorsal column, inverted V sign, also called as the inverted V sign. So inverted V sign is seen in our Also we can do other tests like homocysteine levels and methionine level. So these are all the tests we can do. Next is neurocysticercosis. Basically, it is a parasitic infestation in which Tina solium or Saginata. Now, Saginata is caused by cow eating beef. Solium is pig. So India, pig is eaten more, beef is less. So that's why solium is more common. These cysts are formed in the brain which irritate and cause epilepsy, mainly GTCS. GTCS. So it causes GTCS, and this is the case. Okay, these are the cysts. So these are the cysts we can see. Okay, cyst. Okay, treatment is we give steroids, okay, to decrease the inflammation, mannitol to decrease this, but main is we give steroids, okay, and anti-parasitic agent albendazole, and also treat the seizure. Valproate is used. Okay, Bell's palsy is obviously covered in ENT, so I will not cover much. Is mainly by HSV. Okay, clear. So remember, one is upper body, two is lower body, cause the STDs. Okay, so there is what again paralysis of the face called Bell's palsy. Mostly recover very well. Okay, and decompression can be done. That is covered in ENT also, so I will not cover much. We can give acyclovir, and we can do surgical decompression. What we can do? Surgical decompression. Surgical decompression. Now we see our Ramsay-Hunt syndrome. So what syndrome? Ramsay-Hunt syndrome. What is the story or fun day about the Ramsay-Hunt syndrome? So let's see that. So first and the foremost concept about the Ramsay-Hunt syndrome is what? Syndrome. Okay. So what is the story about the Ramsay-Hunt? Okay. So again, it is herpes involvement of the geniculate ganglia, and mainly there is a vesicle formation at the external artery matter. This is the main thing. Also can have the on the tongue end. This mainly 8th nerve is affected. That's why remember in Bell's palsy it is 7th nerve. In case of Hunt, hearing. So remember Hint is hearing. Hunt is hearing. So mnemonic is Hunt. H, hearing. So if there's a hearing involvement, that is 8th nerve, suspect what? It is Ramsay-Hunt. Okay. Again, treatment if it is caused by herpes, again we can give acyclovir. Okay. So again acyclovir. Next question. We have done the myasthenia, so I'll just skip it. We have done it, just extra point. GBS we have done. This is the antibody. I just skip. So the variation as AIDP, that is acute inflammatory demyelinating polyneuropathy. So it involves sensory, motor, other. If it is axonal, that is motor, is called as Aman. If motor, sensory, both AMSAN, and it can have even the Fisher syndrome. Also Fisher syndrome. Okay. Now antibodies in GBS. So GM1, GM1B, GM1A, okay, GD1B, GQ1B, GQ1B, okay, GQ1B. Now we have discussed that already, so I'll just skip. We have brown sequel, also skip. This table I discussed already. So syndrome, pain lost on opposite, touch lost in same, the brown sequel. Syngomyelia, bilateral upper body loss of pain temperature, but touch is present. Tabes, lower body loss of touch pressure, proprioception, stomping gait. Okay. So lastly, conus medullaris, and this, so I'll write the summary. Remember in conus, anus is affected more. Conus, anus. So anal anesthesia. Remember, conus is anus and medullaris, double. So dullaris is dual. So dullaris is dual. So it's bilateral. So remember, dullaris is both sides. MCQ plus anal anesthesia is there, and person become dull. Dull means important. So there is autonomic loss. So remember, it is dual and more ANS loss. MCQ. So where is ANS loss more? So more bowel bladder dysfunction. So person become dull. Dullaris is dual and bilateral. Dual, bilateral. Okay. Whereas cauda equina, vina is one-sided. So it's vina one-sided. So that's why remember it's one-sided. Suspect cauda equina. If bilateral, suspect what? Suspect our conus medullaris. And when you sit on the horse, you put a saddle to sit, saddle anesthesia, which is in the thigh inner part, saddle anesthesia. So this is the file we have done. Now we start with the cardio. Okay. And I will be closing this file and I'll upload in the group soon. So now let's do our Yes, cardio. So just give me 1 minute. I'll get water because today I took no water, nothing. So let's do the yes ECG first, and then we'll come. Just give me water. 1 minute. Let's continue. Okay. Where are other people? So let's continue. Okay. Now we'll discuss first is the ECG. So who discovered the ECG? It was Carl Enthoven. Okay, and he even got the Nobel Prize for this. Okay, one of the earliest recipient of Nobel Prizes. It record the electrical activity using electrodes. These are normal wave. P wave is due to atrial depolarization. Then we have the QRS, which is ventricular devolution, and we have this junctional point or J point, which is start of the ST segment. So ST start with J point. Then we have is what? So sometime I can't see the chat, it get jammed. I don't know what the problem is. Sometime when I click the chat, nothing is visible. Yeah, now I can see. Okay. So then T wave is ventricular repolarization. Okay. So first question, what is the P wave? Is due to atrial devolution, positive wave, absent in atrial arrhythmias like flutter fibrillation. MCQ, flutter fibrillation. Also absent ventricular arrhythmias like VT, SVT, and VFib. So in these conditions, it is absent. Next question, P, and if it's present, it means sinus rhythm. Okay, I'll discuss it later. P pulmonale, there's the right atrial hypertrophy, and if P mitrale, it looks like a M looking. This is your P mitrale. So remember, if there's a pathology which is causing the mitral valve to be narrow, like mitral stenosis, the left atrial hypertrophy, we get a mitrale. If there's a right atrial hypertrophy, we get P pulmonale. So this is pulmonale. It becomes bigger in size, that is 2.5 millimeter. And if it become wide, that is more than 1-2 seconds, 0.12, it is P mitrale. QRS complex indicate ventricular depolarization. Duration is how much? It is roughly 3 boxes. Remember, 3 boxes rule. So how many boxes? It is 2 to 3 boxes. How? Understand. Each box 1 mm is 40 millisecond or 0.04 second, that is 40 millisecond. So if it is 0.08 to 0.12, that is 2 to 3 boxes. So the normal QR is 2 to 3. Let me show you. See how many boxes you can see. It will be 2 to 3 boxes QRS is present. Okay. Next question. Q is a small wave. Q is a small wave. It is due to interventricular septal depolarization. Normally, it is not seen in any of the leads except V5, V6. If you are seeing, how many hours medicine? It is approximately 10 hours. We've already covered, I think 3 hours. So 7 hours is left. Today I'll take 4 hours, 3 hours I'll take tomorrow. So that is the story. Okay, clear? So let's continue. So it is due to interventricular septal depolarization. So what is the depolarization? It is interventricular septal depolarization. Okay, so what septal? Interventricular septal depolarization, Q wave. Okay, mostly absent in all leads. So it's absent in all possible leads except the V5, V6. If you see Q wave in other leads, is mostly pathological, like bundle branch block, MI, old infarct, pulmonary embolism. We will take it as abnormal. So remember, it is normally not present in the leads except V5, V6. Other leads is pathological. Now comes our R wave. It's a very big positive wave. So it is due to depolarization of the bulk of the ventricular mass, and it is pointing to the apex. So it gives you hypertrophy and cardiac axis. So how do you calculate the cardiac axis? By looking at the R wave. By looking at the R wave. Also hypertrophy, R wave. So hypertrophy axis, R wave. So remember, R wave is indicating hypertrophy and axis. Okay. Now, next question, S wave. So S wave is a small negative wave due to the depolarization of the last part of the ventricle, that is called as postrovasal left ventricle. Postrovasal left ventricle. Okay. Now T wave is a very big positive wave after the QRS. Reason? Ventricle get depolarized. What is the ion? Potassium is the ion channel responsible for repolarization and the T wave. That is why T wave show potassium imbalance. Like example, tall T wave and ST elevation is seen in hyperkalemia. Small T wave is seen in hypokalemia. T wave inversion very important, seen in ischemia, MI, bundle branch block and pulmonary embolism also. These conditions can show a T wave inversion. So T wave can be inverted, but remember, it's mostly related to our ischemia and MI. Ischemia and MI. Now this was the recent exam question. The J wave or Osborne wave. So J or Osborne wave are also called as camel hump. It is a sharp spike after QR. So very sharp. This is a QRS R. This is called as our what? This is a S. This is called as our yes. J wave. Okay, and it is seen in hypothermia. Which condition? Hypothermia. MCQ. Then U wave. It's a very small positive wave after the T wave. After T wave. What is the reason? It is papillary muscle repolarization. Some books say Purkinje fiber, some say papillary, but it's given both in the books. Now, what is the U wave seen in MCQ? So U wave are seen in MI, hypertrophy, but mainly digoxin and hypokalemia. दो याद कर लो, digoxin, hypokalemia. You see T inversion and also U wave. दोनों में same change है क्या? There is digoxin, toxicity. Again, digoxin can also be causing the similar changes. So that's why you see all these changes. Okay. So that is the story here. Okay. Fine. Okay. And the hallmark of this is the reverse tick sign. So there's a ST depression, U wave, and there's a reverse tick sign. It's a ST depression which look like a inverted tick. This is normal tick. This is reverse tick. So where do you see reverse tick sign? The answer is it is seen in the digoxin toxicity. This is the case. Can you see? So this is the U wave and this is the ST depression which is called as reverse tick sign. MCQ. So this ECG can be there. How many? Again, Nachiket, this is something I don't know. How many questions can come? Okay. अगर पता होता तो हम में से सब लोग बताए थे BJP will not get majority. Okay, so वही बात है, we don't know. Okay, but I can assure you it will be sufficient for you to pass the exam. Okay, you will surely get at least 20 to 30 MCQs from this PDF, and if you do it properly, maybe more than 30, but you can pass the exam using this without anything. Okay, so that is the story. Are you clear? Chalo. Next question we see is okay, right? So next question we see is, Radham, yes, for interval and segment and even the rate we use lead to. Also for rate and rhythm. So who is for rate, rhythm and segments? Answer is lead to. First, segment is isoelectric, there is no wave, straight line, call as isoelectric, straight line is segment. Interval contain wave. So what contain the wave? Interval contain the wave. Okay, so interval. Okay, yeah. Next question. It start with the end of S wave and end with the start of T. That's why it's a straight line, and the starting point is called the J point. So what is the starting point is? It is the J. So once again, what is the starting point? J point is the starting point. Now come our ST elevation. First is in the ST elevation, there is hyperkalemia, okay, myocardial infarction, variant angina, constrictive pericarditis. They all cause ST elevation, but remember, convex elevation is MI. If it's a convex like this, it's a MI. If it's concave elevation, that is also called square root sign, it is our, yes, constrictive pericarditis. Please don't make a mistake. These are all important findings. So ST elevation with tall T wave, suspect our myocardial infarction. If there is ST depression, it is ischemia digoxin. Ischemia digoxin is the case. Okay, ischemia and digoxin. This is ST depression. You can see it. So it's going down. So ST depression is there, and this is, remember, if it is iso, you'll see this both at same level. Here they are not at same level. One is below, other is above. So this is your depression. So this is our depressed area. Can you see that? And this is the elevation. It is showing the, either it could be MI, could be hyperkalemia, could be variant angina, or could be constrictive pericarditis. Okay, chalo. Now we see the PR segment. It is the end of P wave to start of QRS. No one use it, skip it. Now come interval. First we see interval is PR interval. Remember why intervals are different? Include a wave. So remember, interval, val में wave आएगा, interval में wave आएगा, interval में wave आएगा. Okay. See, race medicine video is more nowadays. It's more than 10 hours. Earlier I used to do less time, but I am now saying more time is needed because it cover highest. Maximum number of question come from which subject? You tell me. Which subject give you maximum question? बताओ भाई, किससे आएगा? Yes, it will come from medicine. Any exam, INI-CT, medicine is the max. NEET PG, medicine is max. Even FMG exam, medicine. Medicine is the mother of all subjects. याद कर लो, सारे सब्जेक्ट की मदर है ये. सारे सब्जेक्ट में मेडिसिन आनी है. चलो, even surgery needs lots of medicine like antibiotics or control the BP, because without normal homeostasis you cannot do a surgery also. So it's very, very, very important. So this 10 hours of surgery, this medicine video will give you very good score. After exam, give me the feedback. After exam, NEET PG, so I will give you a feedback. So after exam feedback. Okay, give me whether it is beneficial or not. Okay, all those who are watching me live, I want you people to tell me is beneficial or not. Okay, let's start. Next is our PR interval. It includes the P wave. Now what is the benefit? It is indicative of our AV conduction from atria to ventricle. So what indicate conduction from atria to ventricle? It is PR interval. That's why if there's a AV block, increase PR more than 0.20 second. More than 0.20 second. How much time? I told you mathematics. One box is 0.04. Take 4. Two box will be 8. 3 is 12. 4 is 16. 5 is 20. So if it is 20.20 second, it is our AV block. If less than 0.12, maybe Wolff Parkinson White syndrome or maybe some other disorder like like Lou Gevine syndrome. Okay, so that could be the case. Okay, decrease. Okay, so Lou Gevine syndrome. Okay, thank you, Dr. Divya, Dr. Abigail. I know all of you are going to not just pass but do very well in the exam. Okay, now we see the QT interval. Now, what is the story about the QT interval? First question, if it's a normal QT, it is from starting of Q wave to the end of T. So first is, remember, QT include all the wave. That's the case, except P wave. So all wave except P wave is QT. It is QT. So include all the waves except the P wave is QT. Are you clear? Yes, Divya. Okay, I'll also give the NEET PG on 23rd of June. After exam, I'll take a session where I'll be discussing the questions of the NEET PG and I'll be very happy to see your feedback along with my feedback. Okay, next is corrected QT, that is corrected for physiological variation, is our 0.36 to 0.44, that is 9 to 11. Rather, 9, 11. So 9, 11. And what is it increase? Remember, hypos. Remember, hypoclemia, hypocalcemia, hypothermia cause a increase in QTC. Also seen in 1A and 3 anti-arrhythmic drugs. So 1A and class 3 also slow the heart rate, increase the QTC. Now, also drug like ketoconazole, cisapride. Okay, so these drugs tend to cause, even erythromycin, these drug causes increase QTC. So they cause an increase in QTC, and as the QT period increase, it increase the risk of a polymorphic ventricular tachycardia called as TOSETs. Now, what is TOSET is? TOSET is the R wave. It keep on changing its amplitude. It is not fixed. This fixed value is not seen. That is why it is called as twisting of the R wave. It look like a roller coaster or party roller or stream roller, some multiple. So if you see a broad QRS with up and down, it is called as our roller coaster ride. It is TOSETs. Okay. Drug of choice is magnesium sulfates. Remember, heart rate more than 100, broad QRS plus roller coaster like ECG. It is our what? TOSETs. It is our TOSETs. And what is the drug of choice? Magnesium sulfate. What is the causative drug? Class 1A, class 1A and 3 plus hypoclemia, hypocalcemia, hypothermia. That is very, very important. Again, 100% exam question from here. And it also looks similar to which breathing? It looks similar to what breathing? Look like what breathing? Which breathing? Anyone? Tell me. Yes, it look like kind strokes. Yeah, chain strokes. ये क्वेश्चन आता है कई बार एग्जाम में. यस डॉक्टर निक, यू आर राइट, क्रिएटिंग ना इट लुक लाइक चेन स्ट्रोक. ओके, इट इज सीन इन हाई ऑल्टीट्यूड. and heart failure. So, and the heart failure. Okay. Chalo. Next question. Heart rate increases in inspiration, decrease in expiration. This is called as sinus arrhythmia. This is a physiological event. It's not having any pathological correlation. Okay. So what is sinus arrhythmia? It is a change in the heart rate during inspiration, expiration called as sinus arrhythmia. Now, ECG leads. So just remember, there are 12 leads to see the heart from all directions. Like look at this cup. So you can look at the cup from bottom, top, right, left. That is the case. If I tilt the cup, you can see front and back. So that's why you can see front, back, anterior, posterior, superior, inferior. So vertical plane is given by limb leads. They give you up, down, inferior, lateral and medial. So what give you left, right, up and down? That is inferior, superior. That is vertical plane. There are two type of leads, bipolar, which are between the two limbs, 1, 2, 3. I'll show them later on. And unipolar is attached to a single limb. That is why foot is AVF, arm is AVR, right arm, left arm is AVL. So they are like this. So AVF, AVL, AVR. So this is called as unipolar. And these are our bipolar. 1, 2, 3. So these are the leads, unipolar and bipolar. So this is the, which one? This is our unipolar and this green one is bipolar. Bipolar. Done? Okay. Now come horizontal plane. First is anterior, posterior. They are precordial leads, V1 to V6. They are placed over the chest. They tell you anterior, posterior. Anterior are given by V3, V4. Posterior, piche, backside is given by 7, 8, 9. So remember, you are putting the electrodes in the front of the chest wall. So V1, V2 give you septum, IV septum. This is a septum. Why not right ventricle? Right ventricle actually are at the inferior surface of heart. So that's why we are using V1, V2 as septal leads. V3, V4 are the anterior leads. V5, V6 are lateral leads showing the left ventricle. And V7, 8, 9 are posterior. Let me say. So this is V1, V2 septum. V3, V4 anterior. V5, V6 lateral. V7, V8 is posterior. So that is posterior leads. Okay. Now remember, V1, V2 we use for right ventricular activity, V5, V6 we use for the left ventricular activity. Now understand, because left ventricle is thicker and bigger, we get very big R wave in V5, V6 and big S wave in V1, V2. So remember, S is bigger in V1, V2 and R is bigger in V5 and V6. So remember, big R in V5, V6 and big S in V1, V2. And what about the V3, V4? Equal. So V3, V4, they are almost equal. V3, V4. Are you clear? Let's move next and discuss. Thank you very much. Thank you very much, Dr. Vishal. Okay, you are going to do well. You are going to get very good score and marks. But remember what I am telling you, 100% questions will be there from what I am teaching you now. Okay, trust me, I'm not lying. Anyone who has watched this lecture in the past 4-5 years. It's almost 5 years, and I never got a complaint ki sir they are not rude or they are not. Okay, so I'll discuss everything. Just attend with me and it'll be very beneficial. So in right ventricular hypertrophy, remember, very big R wave will be seen in V1, V2 and big S in V5, V6. That is right ventricular hypertrophy. So remember, whenever you see big R in V1, V2, suspicious. Be suspicious of the RVH. Okay. And if it is more than 7R and combined sum of R and S more than 20, it is your right ventricular hypertrophy. See, we see R very big in V1, V2. Okay. V1, V2, and S is prominent in V5 and V6. It's indicative of our right ventricular hypertrophy, RVH. Okay. And in LVH, reverse is there. What will be there? Very big S in V1, V2 and very big R in V5 and V6. See here how big it is. V5, 5, 5, 5, 5, 5, 5, 35 mm. 35. So it's a very big one, and it is 25, 5, 5, 5, 20 mm. So sum is 65. Oh, sorry, it should be 20. So sum is 20, 55. 55 means it's a left ventricular hypertrophy. Okay, so let's do it on a paper and do it with me. Okay, so are you ready to revise with me? Okay, trust me, if you watch, your medicine will be strong, because in the end, in the medicine, this is what people ask. So what are the criteria? If you see R wave big in V1, V2, suspect RVH. V5, V6, very big. Suspect LVH. Then you suspect LVH. So either RVH or LVH. So RVH or LVH. Are you clear? Then how much? At least more than 7 mm. Here books say different, more than 15, 20 mm. Okay, so that is our story. Are you clear? Yeah. Next question, Dr. Fufu, just attend all and you will be perfect in this case. What are the full criteria? Full criteria for RVH is, remember, R in V1 or V2 plus S in V5, V6 more than 20 mm. And for LVH, criteria is R in V5, V6 plus S in V1, V2. How much? More than 35. Okay. So V5, V6. Next is, we'll go to our limb leads. Look at this beautiful diagram I made, my creativity. So this is the person with the heart, and this is lead 1. I told you between right and the left arm. This is lead 2 between the, yes, right arm and the left leg. It's the left foot, left foot. And this is the lead number 3 between foot and the left arm. Okay, 1, 2, 3. It is 1, 2, 3. This is Anthovan's triangle. Anthovan triangle say 1 plus 2 plus 3 must be 0 and 2 is 1 plus 3. That means maximum amplitude of all the wave is seen in lead number 2. So what is lead number 2 give you? Maximum amplitude. Second question, our cardiac axis, the heart direction vector is always parallel to lead number 2. That is why all the waves are maximum in lead number 2. So if you see largest R wave in lead 2, that means axis is normal. Axis is normal. So that is normal axis. If maximum R in lead 2, So that is the case. Are you clear? Now let's see what is the entire summary. Look at this diagram. So this diagram show you our heart. This is AVL, this is AVF, this is AVR. So AVF foot, L is left side, right side is, and this is the left. Okay, so this is AVL, AVR, this is foot. Okay, now remember first question. Lead 1 and AVL show the lateral leads. So what is AVL and 1? Lateral leads indicate our left wall of the heart. Okay. Second is lead 2 is 60 degree. Lead AVF is 90. Lead 3 is 120. Lead 3 is 120. Next is AVR. What are the funda about the AVR is? So it is all waves are inverted. Why? It's looking which direction? Right side. Heart is left side. So it's looking the heart in the opposite direction. So all the waves are inverted. In which lead? AVR inverted. That's why the ECG here looks like this. P inverted, R inverted, S positive, and T again negative. So that's why it show all waves inverted. So what are the inverted leads seen in AVR? So what are the inverted? AVR. And what give positive maximum? Lead to give maximum amplitude. So lead to maximum amplitude. And what is looking at the ground? Inferior leads. What is inferior leads? 2, 3 AVF. 2, 3 AVF. Look at the ground. They are the inferior leads. What is inferior leads? 2, 3 AVF. 2, 3 AVF. Now how to remember? If someone fail F, he feel very inferior to other people. देख रहे हो? This person failed the exam or could not get a good rank. तो उसको क्या हो रहा है? बहुत दुख हो रहा है भाई, बहुत दुख हो रहा है. And as you are very sad, what comes out? The water comes out. That is crying. So this person is inferior because he could not get good rank, good score, pass the exam. So he will now give second or third attempt. So remember, F2, 3 is inferior. F2, 3 is inferior. 100% exam question because it is what they ask in the exam. Who's the lateral? Yes, V5, V6 and AVL1. Also V5, V6 right here. So these are lateral leads. These are lateral leads. So let's revise it. So are you with me? Okay, let's do it. Tell me a very simple thing. Which are the inferior leads? 2, 3, AVF. So 2, 3 AVF are which leads? Inferior leads. Then what are our lateral leads? They are AVL1, V5, V6. Which are the anterior leads? V3, V4. And septal is V1, V2. Please remember them. Is very important for MI diagnosis because you cannot diagnose myocardial infarction if you don't know the leads properly. Are you clear? So don't have to worry. Just do with me. You will learn it. Okay. I'll make a diagram also. This is 1. This is 2. This is 3. 1, 2, 3. And add AVF. It become what? Okay. AVF. Are you clear? So it is AVF. So AVF is there. Okay. AVR is negative. It is negative, yeah, inverted ECG. So who's inverted ECG? AVR, and this is AVL. Now let's do one thing. This is our heart. Can you tell me which direction is the heart pointing? Can you tell me? which direction is the heart pointing? Heart. So heart is pointing towards the lead number 2. So that's why all the waves must be maximum in lead number 2. If there is a axis change, you will get big R wave in either lead 1 or AVL or lead number 3. This is our axis deviation. So let's learn the axis deviation. Look at this first. So what is the question? Normally, if the axis is normal, you should get the biggest R in the lead 2, normal axis. But if the heart is showing a tilt to the left side, let's say hypertrophy there, or heart is displaced to the left side, now the R wave will become bigger in lead number 1. So lead 1, and it will become negative or small in lead number 3, indicating left axis deviation. And in case there's a right axis deviation, right ventricular hypertrophy, you will see lead 3 showing big R. So 3 re. So remember mnemonic 3 re. So 3 is re. 3 is re. 3 is re. So let me write down for you. So first question, what is normal axis? Tell me. Normal axis. Normal axis, maximum R in lead number 2 more than 1 and 3. This is normal. If it is LAD, what is LAD? Left axis deviation. Now the R is biggest in 1 more than 2 and 3, and it can be negative also. Not always, but can be negative. And if it's a RAD, R in 3, okay, it is 1 and 2, negative also. Will you remember this rule? So this rule, please remember, Dr. Yes, Tirathraj, Nick, Kaniga, yes, Ved Prakash, Nick, okay, Fufu, all, please remember this is a rule. If you remember it, you will always get it right, okay? So can I ask you questions? Can I ask you question now? Okay, let's see the question whether you can answer or not, okay? Let me ask you questions, okay? Let's start. Okay, so questions are as follows. So we'll discuss. Look at this. Lead 1, lead 2, lead 3. Question number A. A, B, C, D. Look at this. What is this? A. It is which axis deviation? Left, right, normal, which axis? Here it is max here in 1. Here is negative. So it must be LAD. LAD. Very good. Perfect. Creating happiness. The first to give the answer. It is LAD. Very good. Very good. Other people? Very good. Dr. Ved Prakash, Nick, Tirathraj, Ranjana, Vijay, Anju. Perfect. Okay. Very proud of all of you that you are learning medicine. Divya, Nandini. Very, very, very good. Very, very good. Okay. Okay. ये वाला देखो. ये वाला. Yes, Dr. Sagarika. Very good. This one. This is normal. This is normal. So this is our normal. Okay, चलो. क्या बात है डॉक्टर निज़ाम अजमल. Okay, Nizam, I think Nizam Azmal. Thank you very much for watching. Okay, anything you watch and learn, it is going to be beneficial for you, because what I'm teaching is the simplest way you can learn medicine. I don't use fancy hi-fi language to show off my knowledge or my command over the subject. I use very simple term because I want everyone to learn rather than feeling afraid of the subject of medicine. This one, yeah, it's normal. Yes, you are right. This one. Thank you, Dr. Fufu. Yes. Here it is begin this, so max it is 3. RAD. RAD. Very good. Finally, D. Look at this. What is this? Again, it is right axis. This one is LAD. So please remember, the rule is simple. Always circle the R wave. Wherever you see big R wave, that is the axis shifting. Very good. Very good, Dr. Sohan, Dr. Rajvansh, Arun Chand, Kaniga. Yes. Anju, Safi, Sanjay, Nandini. Perfect. Let's come back. This is the case. Now, see the causes. Left axis deviation is la, la, la. So, la, la, la. So, left axis, it is obese person, pregnancy plus LVH, LBB. Remember, la, la, la. So, left ventricular hypertrophy will pull the current to the left side. So, it will be lead 1 showing bigger R wave, left axis deviation. Whereas, if a person has RVH, the current will go to the right side. So, it will be bigger in lead 3, So, right axis plus RBB. So, just remember, axis shift to hypertrophy side and the block side. Remember that. So, LBB, LVH, you will get the LLL, and RRR is RVH and RBB. Very, very good. Okay. Now we'll discuss conduction defect. Remember, in half an hour, 40 minutes, you have done ECG. And ECG is something which can give you 2-3 questions directly, indirectly. Every year ECG comes in exam. Like NEET PG, there was a question of hyperkalemia. They give the ECG and ask which drug is causing this ECG. Answers hyperkalemic drug, like potassium sparing diuretic causes the hyperkalemia. So hyperkalemia was there. Then recently they asked the question from Wolf, Parkinson, White also. Before that, inferior wall MI also. So I'm telling you, if you don't do ECG, it's a blunder. Now let's discuss the conduction block, AV block. The most common cause of AV block is our vagus nerve. So which nerve? Vagus nerve via M3 receptor. It blocks the conduction. Also, it can cause decreased heart rate, bradycardia, hypotension, and vasovagal shock. Drug of choice is always atropine. So remember, drug of choice for bradycardia, sinus bradycardia, also AV block is always what? It is the atropine. Also in vagal shock and OP poisoning, we give atropine. So atropine is the drug of choice for organophosphate poisoning, vasovagal shock also, and our AV block also, sinus bradycardia also. Okay. Yeah. Yes, delta wave I'll discuss. Now I said, na, it was asked. Okay. Now, what are the treatment? It is atropine. Otherwise, we have to put a pacemaker, temporary or permanent pacemaker, especially if it's a second degree block. Okay, second degree block. So, second degree block, we should put a pacemaker, either temporary or permanent. Now, 3 degrees of AV block, very simple. First degree, increase PR, but no missing dropping QRS. That means after every P wave, QRS is there. So that means there's no dropping. Second degree, missing beats. So it's called as morbits. What is morbid is? Missing beat. So if you see a increased PR, more than 5 boxes, but no, yes, missing QRS, it's first degree. If QRS are missing, you see P wave, but not a QRS, suspect second degree. And if there's no relationship, complete divorce, complete breakdown, this is third degree. So in third degree, there is no relationship. So I'll just write here, third degree, there is no relationship, complete breakdown. So no relationship, AV dissociation is there. P wave can come anytime, before QRS, at QRS, or after QRS. Chalo. Next question, second degree block. So morbits 1, morbits 2. Remember, very simple rule. In morbits 1, PR is constant, and the dropping is very regular. So the ratio could be 2:1 or 3:1. That is, you get 2p wave, then a QRS. 2p wave, then a QRS. But the interval is constant. So this is constant. See? So PR is constant. So PR remain constant, but there are 2p wave. So that means only one QRS come and one is missing. This is called as 2:1 block. So this is 2:1 block. Okay. So 2:1 block. Okay. And it can become third degree. So need to give treatments. What need to give treatment? Second degree morbits can convert to third degree or like complete block. That's why need to give treatment as such. Okay. So need to give treatment pacemaker. Main treatment is our atropine and pacemaker. Morbits 1, the missing beat is not randomly. There's a first increase PR, बढ़ गया, then drop. So that is why there's an increase in the PR, then there's a missing of the beat, also called as the Vanke-Back phenomenon. What is it called as? Vanke-Back phenomenon. What is Vanke-Back? It is morbits 1. Vanke-Back is morbits 1. There's an increase in PR, then a beat is dropped. I'll make it. See, look at this. Okay, I'll make it here. See, PQRS, this is PR, this is normal PR, this is normal PR, then PR is increase, then it is further increase. So PR is increasing and then there is missing beat. So if there is a increase in PR and then dropping, it is called as Vanke-Back or morbits 1. Vanke-Back, morbits 1, Vanke-Back, morbits 1, Vanke-Back, morbits 1. And if there is no relationship between the P and QRS, the P can come anytime, before also, after also with, this is called as third degree AV block. Third degree AV block, no relationship between our P and QRS. So no relationship. So that is the case. Okay. So no relationship, independently beating. Okay. So are you clear here? Okay. Now we discuss our Wolf part. So let me ask you a question. Can you answer me? Okay. Question. Tell me, what is this ECG showing? Anyone? What is this ECG showing? First, look at this ECG. Tell me. This is P. R. PR. Tell me. Yes, there is na. There is increased PR, big PR. See, very big PR. But there is no dropping. No drop. It's first degree. Na. It's first degree. This is first degree. तभी तो कह रहा हूं ना, अरे मोबिट्स नहीं है, इट इज फर्स्ट डिग्री एवी ब्लॉक. ऐसे तो फंसाएंगे एग्जामिनर आपको. इट इज फर्स्ट डिग्री. इज नॉट. दिस इज नीट पीजी ओनली. अंकित भाई, व्हाट विल बी नीट पीजी आस्किंग यू? सेम एवी ब्लॉक, वैंकी-बैक, मोबिट्स. थोड़ा होता है यार, पेशेंट है तो डिजीज चेंज हो जाएगी. ऑल एग्जाम, एफएमजी, नीट पीजी, द क्वेश्चन आर सेम. दे विल आस्क द ईसीजी. ईसीजी डजंट चेंज. ऐसा नहीं होता कि एफएमजीज के लिए अलग ईसीजी होती है और नीट पीजी वालों के लिए सेम होनी है. मेरे भाई यही आना है, पढ़ो. चलो. सो अब देखो, ये वाला बताओ. this one. Diagnosis of this one. P and P. What is there? Is missing. Always missing, only once. It missed one, then again it came, then R. So that's why it is our increased PR and miss. Diagnosis, it is Vanke-Back. यार फर्स्ट, कंफ्यूज मत हो प्लीज. मैं फिर से बोलूंगा दिव्या, first degree AV block, there is no miss. Morbitz 1 is miss. This is Wenckebach, which is also called as Morbitz 1. Confuse मत हो, ये है Morbitz 1. अब समझ में आ गया? Morbitz 1, there is a missing beat. Morbitz 1 missing, and it is second degree AV block. अब सही है? Second degree AV block. I want everyone to get the concept correct. Otherwise, I could have just taken a liberty of teaching very fast. ठीक है? So we are not doing a drama. 2 hours we'll discuss some important topic and 2 घंटे में आप क्या मेडिसिन सीख लोगे? Do you want to learn in 2 hours all the medicine? मैं भी बस ऐसे करूँ खोल के ऐसे, ये हो गया डेल्टा वेव इज सीन इन वुल्फ पार्किंसन, देन दिस पैटर्न, ओके, दिस इज एम पैटर्न, आर पैटर्न. दिस नॉट टीचिंग, ओके, और रिवीजन आल्सो, इट्स जस्ट टाइम पास, ओके, ठीक है, और जस्ट क्वेश्चन डिस्कशन. Then how will you revise the theory? Some place you're just doing the question discussion. Question discussion is not revision. It is only for, yes, clearing your doubts in solving the question. Okay. So second degree. ठीक है, चलो ये वाला बताओ. ये क्या है? This one. This is second degree. This is Morbitz 2. Second degree. Second degree. And if you get ECG like this, okay, P, 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 QRS, T. This is our third degree block. Here you see they are not having any relationship, complete breakdown. This is P, this is P, this is P, this is P. So here P merged with the T, here T, P, much gap. So that's why this is third degree. No relationship. No relationship is third degree. Okay, now let's see our very special 100% exam question, WPW syndrome. What is that? Wolf Parkinson White syndrome, WP. It is basically bundle of Kent which bypass the AV node. So what does it bypass? It bypass our which node? It bypass our AV node. Call as what? Bundle of Kent. What Kent? Bundle of Kent bypasses our AV node. Next question. Impulse reach ventricle faster. So it reaches the ventricle much faster and cause a early depollution which give delta wave. So delta wave is this. This is normal, no delta wave. This is the delta wave. So delta wave indicate ventricles are depolarizing much sooner because can't give faster current. So remember can't. And कैसे याद करना है can't को? Hema Malini used to do ad. You all know. So Hema Malini used to do a ad for a company. Which one? Kent water purifier. So I'll give a mnemonic if you want to remember. Very easy mnemonic. See. So Hema Malini used to advertise this. कहाँ गया हमारा Kent water purifier? पता नहीं कहाँ चला गया. So I put it here. I don't know where it went. Okay. So she used to advertise Kent water purifier. So remember it is Kent water purifier. So bundle of Kent is seen in this case. What is there? Bundle of Kent. Bundle of Kent. Okay. Chalo. Next question. Okay. The impulse reaches ventricle fast, but now the ventricle will take long time to depolarize because of the normal activity is getting some refractoriness. So that's why you get a short PR. We get a short PR that is less than 0.08 because of the early D, and there is a increase QRS more than 3 boxes. So remember what is the story? Story is if you get a decrease PR and increase QRS, it is your diagnosis. And what increases? QRS increase. increase QRS. This is WPW syndrome. So what is WPW? Once again बता रहा हूँ, if ventricle depolarize sooner, so this will be like this. This is delta wave indicating early depolarization. Then ventricle take long time to finish its entire depolarization. So QRS is broad, more than 3 boxes. That is more than 0.12 second. And PR is shortened because impulse reach ventricle much sooner. So that's why decrease PR. तो बस याद कर लो, decrease PR, increase QRS. Decrease PR, increase is seen where I'm explaining ECG only, bhai. Okay, so that is Wolff-Parkinson White syndrome. लो भाई ECG में देखो, टाइम का इशू है भाई, वरना in my regular class I explain everything properly with detail example. It's a revision class. I'm doing my level best to explain also. This is a normal ECG, normal to nahi, is a ECG of WPW. What do you see? This is P wave, this is QR. So within 2 box, what started? Within 2 box, we see the delta wave. This is a delta wave. So this wave indicate our early depolarization. Are you clear? Normal ECG, you only see a very straight rising R. If you see a curved R rising 1, this is called as our delta wave. Are you clear? This is delta wave. Are you clear now? Dr. Dalem, Vitai? This is the case. Chal. Let's go back. Now, what is the problem of WPW? WPW create a re-entry pathway. Remember, normally current passes from atria to ventricle and stop. But now because of bundle of Kant, you are allowing the current to go back towards the atria and again come back. So that's why it create a circuit. And this circuit create the re-entry of the current back to the ventricle, which causes the ventricle to contract multiple times, depolarize and contract. That's why you get a tachycardia, which is not coming from the normal pathway SA node and then AV node. It is coming through the re-entry of the current in the circuit. That is why it's called a supraventricular tachycardia due to re-entry or circus movement, also called as re-entry or circus movement. So re-entry or circus movement. Okay. So re-entry or circus movement. Okay. That is why we need to treat, we need to remove this bundle of Kant. So that is why we need to remove it. Otherwise the circuit will become a loop circuit where current will keep circulating again. So that is why what we need to do, we need to remove bundle of Kant. So that is why treatment of choice is radio frequency catheter ablation of Kant. So we will do a surgical procedure. Yeah, it can be seen on the lead to the west. Okay. Okay, Dr. Nick. Yes, we'll see. So that's why we need to remove bundle of Kant. We need to remove bundle of Kant. And for that we use a, yes, surgical procedure. It is ablation. Okay. Now question is, if you don't have the, like accessibility of surgery right now, what do you start? We give class 1C antiarrhythmic, which one? Plaquenil and propafenone, but the treatment of choice is our radio frequency catheter ablation. Okay. Okay, so we'll take a break, 10 minutes break. I'll start at 10 p.m. Class is till 11:30 p.m. See, if you have not worked hard in the past 5-6 months, then doing 1, 2, 3 hour extra work is not going to harm you. It's up to you. This 3-4 hour session can make you pass or fail the exam. Imagine 5-6 years of study, then preparation for the exam, and now not doing important stuff, just depending. अरे कहीं से भी कर लो, किसी भी टीचर से कर लो, कोई मेडिसिन टीचर, all are good, all are great faculties. ठीक है, just do it ना. It's up to you. If you're not doing, all are bad. ठीक है, if you're doing, all are good. So teacher अच्छे बुरे नहीं होते, स्टूडेंट्स के ऊपर होता है कितना सिंसियरली दे कैन यूज. इट्स लाइक सेइंग व्हाट इज गुड और बैड. ओके, व्हाट इज गुड? wheat, rice, all are good. You can eat anything. Only thing is some are not suitable. Maybe you have the celiac disease. Chalo, so I'll take a break and everyone, I am back. Please join in. Hello to everyone. Hello, hello, hello. Where are other people? I think they are also having dinner. Yeah, I'm here back. Okay, chalo, let's continue. Please join in. Started. Yeah. Obviously, I was eating the food, so got a bit late. Join in, please. Join in. Where other people? I think most of people have quit. Yeah. I think most people have left. Let's continue. Okay. So now if there's a bundle branch block, it could be right or left. Remember the funda. First, if the block is occur, ventricle will take longer time to do the depollution. So the QRS become broader. It's more than 0.11 second. And there is the same side axis deviation. So LBB will cause a LAD. RBB cause a RAD. Plus T wave inversion can be seen. And this is slurring or notching of QRS. Cause a classical M or W pattern. Just remember a very simple mnemonic. If you see M in V6, it is our LBB, and if you see M in V1, it is RBBB. Let me make it for you like this. Okay, if this is what you are seeing, this is our M. This is LBB. Look at this one here. I'll make it here. Space is not there. Okay, try to make it here. So this is RSR. So RSR. So look at the shape. This is the M. So M in V6 and M in V1 indicate if there's a M, look at this M. If the M is in V6, it is our yes, LBB. If the M, this is the M. If the M is in which? It is in our V1, RSR. It is RBB. So that's the funda. I think chat is problem. Okay. Okay, Dr. Lakshman, congratulations for passing. I congratulate on behalf of entire team, NLC. Best of luck. Yeah, chat has an issue. There's a delay. I can't see the chat. Thank you very much, Divya. Yeah, I'm trying my level best. Okay, Dr. Vicky, just please be positive. Working hard is the only solution, nothing else works. Now, we'll discuss arrhythmia. First, for arrhythmia, remember heart rate. Heart rate is given by 1500 millimeters, which is the number of strips covered in 1 minute, divide by RR interval in millimeter. Remember, we take RR, this is the case, okay? I'll discuss the doubts later. Okay, let me finish this. In the end, I'll take a discussion session where you can ask me anything. Right now, let's do it. Okay, our target is let's finish cardiology. Okay, tomorrow I can do the respi and nephro easily. Okay, respi, nephro, GIT will take around 3 hours. So let's do this today. Tomorrow we'll take a 3-hour session and finish. Okay, tomorrow I am planning to start the class earlier, let's say 5 o'clock, so that I can cover everything without any problem. Are you clear? So that is our target for tomorrow. Are you clear? Chalo. So let's continue. Let's discuss. Okay, let's see. So if the RR tomorrow time I'll update, I think it will be 4 or 5 p.m. Okay, 4 or 5 p.m. So I will postpone my offline class tomorrow so that I can take a early online class. Okay, so tomorrow timing I'll update. It's I think 4 or 5 p.m. I have a flight also to Kolkata. I'm going there for 2 days for offline class in Bharti Institute. So I have an offline class tomorrow. So that's why I will do it fast, then come to online, then take a flight, go to Kolkata, teach Kolkata students, come back and again teach you. Very hectic high flight. Okay. So next question. What is the RR? If RR is constant, it is called as regular rhythm. And if there is P wave always followed by a QRS, okay. So P wave, then QRS followed by QRS, it is called as sinus rhythm. So what is regular? Regular is when RR is constant, it is called as regular rhythm. Let me show you. Now we are seeing the rhythm. Look at this. So look at this ECG. First, let's calculate everything and we'll do it. So in this ECG, take lead number 2. Check RR interval. Is RR interval changing or same? It is almost same. So RR is constant. What is it called as? It is called as regular rhythm. Then next question. So RR is regular. RR is regular. Second, P wave is always there before the R. That means it's a sinus rhythm. Why sinus? P is present. RR is constant. What is the heart rate? Can you tell me the heart rate? What is the heart rate? Count the boxes. See, 5, 5, 5, 5, 5. See, this is a 5 box, 5 box, 5. Total 25 is 300 by 5. That give you 60 per minute. Okay, I am good, Dr. Philadelphia. So this will be 60 heart rate. Okay, so that is how you interpret a ECG. Now come. If R wave is followed by QRS, it is called as sinus rhythm. What is it called as? Sinus. And heart rate less than 60 is called as bradycardia. In bradycardia, we give what drug? We give the treatment of the cause. Like if it's the inferior wall MI, correct the treatment of MI. If it is due to vagus nerve, we have to give the correction, maybe atropine. If due to some drugs like beta blocker, we might stop the drug. Or if it is due to some hypothermia, always correct the cause, treat the cause. Then drug of choice is IV atropine. So we'll give atropine. If still heart rate remain low, you have to give adrenaline. And if still not corrected, then we have to put a pacemaker. So treatment of bradycardia, atropine, adrenaline, and finally pacemaker. Okay. Okay, Nikhil, how are you, bhai? I hope you are doing good. Internship must be over and you must be preparing for PG. Best wish for you and do everything. Okay. Okay, Dr. F. Mukherjee, you can meet me in Kolkata. I don't know where I am having class. Maybe NG Car Memorial Hospital. So if that is there, you can come there. Okay, chalo. Now tachycardia. Heart rate is more than 100. Tachycardia, heart rate more than 100 up to 250. Above 250 is flutter. Above 250 is flutter. If P wave is present, it's a sinus tachycardia. And in sinus tachycardia, first we decrease the heart rate using vagal maneuver. Which vagal maneuver? Like carotid massage. MCQ. And drug of choice is beta blocker or we can use CCB. So what is the treatment? First, try to decrease the heart rate through vagal maneuver, and then we can give beta blocker. Okay, and it is mostly because of increased sympathetic anxiety, pain, or any kind of drug also can trigger the sinus tachycardia. If P wave is absent, it's either a VT or SVT. तो याद कर लो, if P wave absent, it's a VT or SVT. MCQ. So VT or SVT. Now remember, patient complains of palpitation in most tachyarrhythmias, in both tachycardia. So he feel anxiety also. There is sometimes increased sympathy. So tachycardia, sweating, tremors, all can be seen. Now remember, if sudden onset, it is called as PSVT, that is paroxysmal. P means paroxysmal. Is sudden. Now remember the rule. If you see the width is more than 3 boxes, okay, that is 0.12, some books say 0.14, it is VT. It's a VT, V. So VT look like a shape of V. Remember, very simple mnemonic, VT look like V's. So if you are seeing V's, think of it as the VT, wide QRS. If it is very narrow, slim, if it is slim, it is SVT. So slim is SVT, wide is VT. Wide is VT, slim is SVT. So slim is SVT. Next question. So this is the, yes, SVT. You can see QRS is just 2 boxes, 1, 2. So 2 box means it is very, very narrow QRS, and there is no P wave, no P wave. So remember, no P wave, it's SVT. Now let me ask you once again and explain you with my story. See, first, if heart rate more than 100, it's a tachycardia. Okay, check P wave. Check P wave. P is present, P is absent. If P is present, it's sinus tachycardia. Treatment, beta blocker. Beta blocker. If it is absent, then check QRS. Check QRS. If QRS is wide or slim, that is narrow, like this. This is SVT. If it is wide like this, this is VT. Please don't forget this. This is VT. This is VT. This is VT. Yes, more than 3 boxes. This is less than 3 boxes. या पक्का कर लोगे, रेगुलर है, इट्स वेरी रेगुलर, नो P wave. Okay, so slim is SVT, slim is SVT. One question for sure, slim is SVT, and wide W shape. ये देखो W बन गया ना. So अगर W बन रहा है आपका ऐसे, this is wide is VT. So W or V is VT. Okay, now management. Now remember first rule. If BP low, that means patient is unstable. That is BP low, less than 90/60. Unstable patient, hemodynamically unstable. Hemodynamically unstable. What we should do? Always do DC cardioversion. So we give a low energy electrical shock, DC shock, and restore the rhythm, DC cardioversion. 100 time exam question. If BP is low, drugs will not be working. We have to go for DC cardioversion. So what we go for? DC cardioversion. DC cardioversion. Clear? So DC cardioversion. And if BP, patient is stable, use drugs. And if fail, again cardioversion. Again go for cardioversion. Is it clear to all of you? So I'm giving the best summary possible. Use it to solve the question. Okay. Now what are the drug treatment? Let's see. Drug treatment for SVT. Okay, we will first try vagal maneuver. So first is vagal maneuver if possible. First try vagal maneuver. Okay, if vagal maneuver don't work, then we can go for drug. What is the drug? Adenosine. So the treatment of SVT, PSVT, adenosine is the drug of choice. Only problem, it causes bronchoconstriction, plus it is short acting. So if asthma or prophylaxis, use verapamil. So remember, drug of choice adenosine, but if asthma or prophylaxis, then we use verapamil. And if drugs fail, we can go for cardioversion. Now VT. VT show bizarre QRS, fusion and capture beat. What is the fusion or capture? It's a normal looking QRS during the VT. This is the VT and this is your normal QRS. So if you get a normal QRS between the VT, this is called as our what? Capture beat, and the merger create the fusion beat. So initially you get a fusion beat with a feature of both. It's a T wave, this is a broad QRS, and then you start seeing what? Normal QRS. This is called as capture beat. Also you see Broda sign, we can see the Josephson sign. So many findings. Then concordance can be there. So multiple findings are there, but just remember the simple thing. If the patient is unstable in a VT, always go for cardioversion. If stable, amiodarone is the drug of choice. So IV, amiodarone and lignocaine can be used. And if not responding or unstable, cardioversion with low energy synchronized DC shock. Low energy synchronized DC shock. It brings the rhythm back to normal, and we can use AED, automatic external defibrillator, to restore the rhythm back to normal. Next question. If there's a flat line, this is called as asystole. This is our cardiac arrest. So in cardiac arrest, don't do any kind of defib or cardioversion. Treatment is cardiac arrest में CPR with adrenaline and ECG to check if shockable or not. If shockable rhythm, if there is a shockable rhythm, then we will defibrillate by applying the pedals of AED and give the DC shock. Which one? The desynchronized DC shock. Okay, let me now teach you. First, these are shockable rhythms. So we are discussing what thing? Shockable rhythms or flutter and fibrillation. Number one rule, in flutter the rate is above 250, less than 250 is VT. So VT is less than 250. So VT is less than 250. Fibrillation is more than 350. More than 350. Okay. Now both are medical emergency. Patient has collapsed. There is no pulse and ECG shows activity. That's what's called as shockable rhythm. So remember, in cardiac arrest, flat line. In case of fibrillation, flutter, there is electrical activity, although it is not like a regular activity. That's why it's called as what? Irregular activity. Now first question, treatment is same, immediate defibrillation. Immediate defibrillation with a high energy, not low energy, high energy unsynchronized DC shock. What is given? Unsynchronized DC shock. Where do we use synchronized DC shock? Synchronized DC shock is used in cardioversion. So cardioversion is restoring the normal rhythm, and that is done using the what thing? Our low energy 50 to 100 joule synchronized DC current. If it's a flutter or fibrillation, we go for our high energy desynchronized DC shock. Energy could be up to 360, and CPR followed by CPR for 2 minutes. Again defibrillator. Okay, again defibrillator is applied. Now comes the question. This is fibrillation. In fibrillation, the rate is very high and you cannot identify any of the waves. This is the hallmark. The distance between the peaks distance is 3 to 4 millimeter. The rate become if 4 millimeter, 375, 3 peak is 500. 3 peak is 5. Dr. MS, congratulations for passing. I am very, very happy. Yes. Okay, don't think it's 5th attempt. Main thing is you pass. That's more important. Not everyone gets success in the first attempt. Abraham Lincoln lost more than 10 elections only then he was able to become president of the United States. And once he became president, he was faced with the civil war. The southern state wanted to separate from America and create their own country. So he fought the civil war rather than agreeing to their proposal to continue slavery. Again, he succeeded. Same Colonel Sanders. Colonel Sanders, he failed multiple times. He used his last of the saving, whatever he had, to start selling chicken, Kentucky Fried Chicken, KFC. He became successful. No one gets success in first attempt. If you get, it's very lucky. But again, it's not going to change anything. At the end, what matters is not how you start. It is how you end. Clear? No one remember Gautam Gambhir that much. Sorry if Gautam Gambhir is there and might be angry. But no one give as much respect to Gautam Gambhir despite scoring highest run in the World Cup final. But people remember the six hit by Dhoni. Reason? People remember the last, not the end. So how you end your journey will decide. Hitler failed. That's why people abuse him. Imagine if Hitler would have won. People would have made him like some kind of god, Alexander, some kind of, like Genghis Khan. Why? Because he would have been successful. He is the ruler of the Europe and something. That's why I'm telling you, last step matters, not the first step. If you're successful, you are going to be very, 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 happy. That's what my belief is. In the end, I should be successful. Now, remember the ALS. First is check safety. Yaad karo. Before saving others, save your own ass. Okay, so that is why we should always, save our own, ass. Okay, so check the safety of the scene. So check the safety of the scene. Then check for responsiveness. Shout for help. Look for pulse and breathing. Look for pulse and breathing. Okay. Now, if pulse, breathing is absent, start CPR. If present, wait for the emergency responder to come, the ambulance to come. And if there is no breathing, give CPR. What is the breath? It is our 6 second 1 breath, and total 10 breaths per minute. Okay, 10 breath per minute. Okay, chalo. वही तो कह रहा हूँ ना, India won all the matches in World Cup, but people don't remember this World Cup at all. Reason? They lost in the end. People remember 83 World Cup, although India lost to many teams in that World Cup. But why? Because you won. So the winner is what people remember. No one remember the losers. No one remember the loser. Okay, let's continue. Okay, now start the CPR. 30:2 ratio. 30 compression, 2 breath, and wait for AED to arrive. Once AED come, you check the ECG. If there is a shockable rhythm, you will give the shock and then CPR for 2 minutes. If it's non-shockable, asystole, flatline, resume the CPR and again check the rhythm. Okay. Now atrial arrhythmia. First is atrial flutter. No P wave, but replaced by sharp flutter wave called as a sawtooth, in which there are 4 small spikes and 1 long spike of the R. And RR is very much constant. That's the main thing. RR is constant, so regular rhythm is there. Heart rate can be normal or increase, but main thing is management is same as AFib, which I'll discuss soon. Now comes our AFib. The P wave is absent. What is absent? P wave is absent. Rather, there is an irregular fibrillating activity. What is the activity? Irregular fibrillating activity of atria, of the atria. Okay. So there is normal QRS width, but the RR interval is not. So the biggest finding is RR interval is not constant. Here 3 boxes, here 2.5 box, here 3.5, here 2. So RR keep changing. RR is changing. That's the biggest hallmark, and no P wave. So if you see no P wave, RR changing, this is your main hallmark. It is your atrial fibrillation. Patient might complain of palpitation, the episodes of syncope, giddiness, fainting, all there. And pulse is the biggest finding, irregular pulse, and in JVP, A wave is absent. These are the findings of our JVP. Are you clear? So JVP findings. Okay. Now, what are the treatment? A, B, C, D. A for amiodarone or dofetilide or ibutilide, which are class 1 antiarrhythmic for rhythm control, also called as drug cardioversions. What do you give for drug cardioversion? A for amiodarone or class 3 agents. Then for rate control, we use beta blocker or CCB. If there's a tachyarrhythmia, we can decrease the rate using beta blocker or CCB. So that is the case. And if there's a AFib with heart failure, congestive heart failure, we go for digoxin. So digoxin is nowadays used in AFib with heart failure, otherwise not used very often. Now, let's revise it. So what is the treatment of AFib is? Answer first. वही पहले चेक करो BP less than 90, cardioversion. So we will go for cardioversion. If BP more than 90 is stable, you start with A, amiodarone. Then we can use B or C, that is beta blocker or CCB. And if heart failure, then there is no other option, but we are going to go for what condition? If there is a heart failure, yes. So if heart failure, we are going to go for which condition? Heart failure. Yes, digoxin. So heart failure, we will give the digoxin. So heart failure, digoxin. Chalo. Next question. Next is we are discussing, okay, this is done. So we discuss. Plus also we need to give anticoagulants, low molecular weight heparins, oral warfarin, abiximab. We need to give anticoagulants. Why? Because there's a high risk of thromboembolism. It's a very, very important topic. A patient with AFib or aflutter, high risk of thromboembolism, which can cause stroke, MI. That's why we need to give anticoagulants in this patient. So let's revise it. This is flutter. Can you see sawtooth? This flutter. If you see this wide V shape, it's VT, cardioversion, else amiodarone if BP is low. If you see irregular RR, it is AFib. So this is irregular, it is AFib, ABCD, amiodarone, beta blocker, CCB. If you see very high activity, very fast, but there is no wave identified, irregular, this is AFib, give DFib and CPR. If you see very narrow QRS complexes, it is PSVT, and what do you do? The first is vagal. This is the vagal first, and drug of choice is, yes, our adenosine. Prophylaxis can be done via, so prophylaxis can be done via, yes, verapamil. So prophylaxis by verapamil. And finally, what is the last thing? It is asystole, in which we have a CPR and adrenaline. So CPR and adrenaline. Now let's see the hyperkalemia. Hyperkalemia, basically you see potassium should be more than 5 millicrant per liter. So if potassium crosses more than 5, this is hyperkalemia. ECG will show tall tented T wave. Which waves? Tall tented T wave and ST elevation, plus there is also increased PR interval. Later there could be asystole or fibrillation. Treatment is we give 10% calcium gluconate for membrane stabilization. Drug of choice is insulin and beta 2 agonist salbutamol as an inhaler. So we give salbutamol and insulin. If hypokalemia, potassium less than 3 or 3.5, some books say, we have small T wave, increased QTC, increased PR, bradycardia, and again heart can stop in diastole or systole. Heart stops in the case and we will give potassium supplement KCl. Potassium supplement KCl. And risk is there? Yes, torsades can occur. Okay, and torsades can occur. Okay. So that is the case. So if hypokalemia, remember PR interval is decreased in both the conditions. This was the question asked in the recent exam. What happens to PR interval? It is increased in both hyperkalemia also, hypokalemia also. So if you see increased PR interval, suspect what disease? Suspect our what disease? It is our, yes, hypo also, hyper. Now in hypocalcemia, there is basically what? There is serum calcium less than 9. So there is an increased interval. Both ST elevation is there and QTC prolongation. So sorry, ST prolongation and QT prolongation. Both are prolonged. And we give calcium gluconate for the treatment plus calcium vitamin D supplements. Okay. Now hypercalcemia, increased calcium more than 11. Again here reverse occur. It's a shortening. So याद करना hypo में बड़ा हो जाएगा interval, hyper में shorten कर जाता है. Treatment we can give is loop diuretics, correct the cause. Loop diuretics, correct the cause. Might need dialysis also. So that is the case. So now we come to the next topic, that is our coronary artery disease. Now remember who supply the heart. Right coronary artery supply the inferior wall of the heart, which is mainly composed of right ventricle. Lead uses 2,3F. We have discussed already. Right coronary artery give two branches, LAD, that is left anterior descending artery, which supply the anterior wall. So it supply the anterior wall. So who supply our anterior wall? Lard. Lard प्यार से आगे बच्चों को लाओ, anterior. And circumflex is your lateral wall. So circumflex supply our lateral wall, and that is why its leads are AVL1, V5, V6. AVL1, V5, V6 is what? Circumflex. So it is our circumflex. Circumflex. Okay. Now remember the story. If it is inferior wall, it's right coronary artery, what lead will show the changes? 2, 3 AVF. If it is LAD, you will see lateral V, AVL and 1. AVL and lead 1. And if it is LAD, you can get multiple involvement. If it is anteroseptal, it is anteroseptal. Like this is the anteroseptal. In this case, you get V1 to V3, V4 changes. Anterolateral, V2, V3 to V5, V6. And if it is V1, it is the anterior wall, extensive anterior wall. It is V1 to V6, AVL and 1. Okay. So if V1 to V6, AVL1, it is extensive anterior wall. So remember that's the case. Also remember anterior is V3, V4. Septal, yeah, उल्टा लिखते हैं ना, लिखो, this is lateral. Low lateral, AVL, this is high lateral. So remember AVL or 1 is called as high lateral, whereas V5, V6 is also lateral but called as low lateral leads. Whereas our anterior is, septal. Septal is V1, V2. Anterior is V3, V4. That's why if you say anteroseptal, it is V1 to V4. ये हो गया ना आगे का. If you say anterolateral, then septal leads are not involved. So it is V3 to V5, V6 is called as antero. But if everything is affected, V1 to V6, then it is extensive anterior wall. Extensive anterior wall. I know it might be appearing difficult, but you have to do it. There is no other option, because in the end, either you pass or fail. It all depends on how much hard work you are putting. To become a good doctor, we cannot ignore them. Okay. If you don't learn them, don't do them, obviously it's going to be a problem in the exam. So that's why my request is please, please, please do them properly and learn it. Now we'll discuss the CAD. CAD is basically coronary artery disease. What is CAD? Is coronary artery disease. What happens? The coronary artery get narrow, that is stenosis, and that could be one or multiple, and it is most commonly caused by atherosclerosis. What happens there? So dyslipidemia is there. A patient who's diabetic or genetic, obese, sedentary lifestyle, they have accumulation of cholesterol in the vessels, and it create plaques ultimately, which can lead to further narrowing and can even trigger the injury to the endothelium and trigger thromboembolism, which causes complete blockade of vessel, and that is why it's a very serious problem. Other causes of narrowing could be vasospasm, which is responsible for variant angina, could be drugs. So drugs can also be responsible for spasm. So some drugs can trigger the angina by causing vasospasm. Then emboli can also block the vessel, and that is by high risk of MI, in this case infection. Even there could be, yes, compression of the artery by condition like Takotsubo cardiomyopathy. There's again coronary vasospasm. So all of these can cause the narrowing of the vessel and decrease blood supply to the heart. Now risk factors for atherosclerosis. What are the risk factors? They are obesity, diabetes, dyslipidemia, alcohol, smoking, sedentary lifestyle, genetic. झंड जिंदगी याद कर लो. Indians are 4 times more at risk for our lifestyle disease, especially coronary artery disease. So our genes have this problem. We are very highly prone to this diseases. Okay. तो थोड़े genes हमारे अजीब से मिले हमें. Indian genes are bit चल. Next question. Most common vessel involved in CAD is LED. कार्ड लाड. तो याद कर लो, कार्ड में लाड है, लाड में कार्ड है. कार्ड लाड लाड कार्ड. सो याद कर लो, कैड लैड लैड कैड, कैड लैड लैड कैड. ओके, डन. नेक्स्ट क्वेश्चन. ओके, also called as widow's artery. Why? Because coronary artery disease MI is more common in male. So that is why husband will die. So wife will become what? Widow. So wife will become widow. Okay, clear? Now in female, estrogen is cardioprotective. That is why female have less risk of CAD before menopause. But after menopause, the risk is almost same in female also. So what are the benefit of estrogen? Is it harmful, protective? What do you say? Estrogen is very protective now, but it is also very important that it is very important for longevity. So that's why longevity is more in female thanks to estrogen protecting the heart. Okay. Clinical features. Remember, low blood flow will cause what? Ischemia. So as the blood flow is less, there will be ischemia and it causes chest pain. Retrosternal left side, this side. Okay. It's called as angina pectoris. And the pain radiates to the left shoulder and the left arm like this, and can even go towards the face also. So that's why pain is spreading like up and left, and this is our pain. And the patient might present the classical presentation, clenched fist over chest like this, and very painful expression. ऐसे लग रहा है this is your Levine sign, and this is Levine. So इसके लग गए, ठीक है, तो इसके लग गए. Okay, Levine. And there could be sweating, palpitation. Yes, patient might be anxious, and it is increased sympathetic. So there's an increased sympathetic, but remember, if there's a decreased heart rate BP, it could be inferior wall MI. So don't ever ignore if there is increased sweating, palpitation, heart rate BP might be what? So might be what? Okay, also BP. That's why sometimes we give drugs to decrease the BP. But if there's a decreased BP, decreased heart rate, suspect inferior wall MI. So which MI? Inferior wall MI. Now, treatment of angina. Remember, any angina, treatment is nitrates. What do they do? Like isosorbitrate or isosorbate. So we can give sorbitrate or isosorbate. So sorbitrate. So what drug we give? Sorbitrate or isosorbate. Okay. Now nitrates have very high first pass, liver break them. That's why cannot give them orally. They are given sublingually. MCQ. What are the mechanism of action? They increase NO, nitric oxide. What does nitric oxide do? It causes the vasodilation. Thank you, Dr. Sumit. Congratulations for passing. And again, thank you very much for still regarding your teachers, thanking them. Thank you very much. Today, I will give the PDF of this annotated and it will be there in the Google Drive. Divya, click on the description. ये देखो मैं आपको दिखाता हूँ. ये description है ना बच्चा. यहाँ पे आप क्लिक करना मोर पे. देखो यहाँ पे ये करते ही आपका ये डिस्क्रिप्शन खुल जाता है. तो जैसे आप वीडियो के नीचे क्लिक करोगे डिस्क्रिप्शन में आपको गूगल ड्राइव का लिंक मिलेगा. गूगल ड्राइव के लिंक में ही अपना सारा काम छुपा हुआ है. सो माय ओनली रिक्वेस्ट इज जस्ट सर्च द गूगल ड्राइव, यू विल गेट इट. ओके, डिस्क्रिप्शन में. वेरी गुड. यस, कुशाल इज राइट. नाउ नेक्स्ट क्वेश्चन. What do? They cause vasodilation through cyclic GMP. Nitric oxide is produced from arginine. What is it produced from? It is produced from arginine via nitric oxide synthetase. So via what thing? Via nitric oxide synthetase. So nitric oxide synthetase. Now there are how many types of angina? There are two types of angina based on pathophysio. One is, remember, Prince. Prince क्या होता है? राजकुमार. They don't work. So pain at rest is called as prinzmetal. क्या कहते हैं? Prinzmetal. And if it is classical, I'll tell you classical. A student tell marks of his class test. And the parents, when they check his class test result, they have chest pain. Oh, ये क्या कर डाला? This is called as classical. So class test का result क्या करेगा? Emotion. So emotion, exertion, exercise, excitement. This is classical. Then Prince keep on sleeping and they develop chest pain. This is called as our what? Variant angina. तो याद करना classical कब होता है? जब class test बताते हो classical. Okay? और a person is running. भागते भागते बहुत ऊपर निकल सकता है. That's it. और person go for roller coaster. Roller coaster. As the roller coaster moves sympathetic, increase the heart rate. Heart start pumping faster, and now the heart need more oxygen. But artery is narrow, so that is why ischemia is triggered, causing chest pain. That's why chest pain occur on what? Excitement, exercise, exertion, emotion. That's why if your parents feel chest pain after looking at the result, maybe they are having coronary artery disease. Coronary artery disease. Are you clear? So remember, if pain occur at rest, it's variant angina. Pain occur on exertion. This is our which condition? It is our classical. Are you clear? Now, what is classical caused by? So classical is caused by atherosclerosis. So what is classical caused by? Classical is caused by atherosclerosis. So it's caused by the atherosclerosis. Done. And what is variant? It is spasm, and spasm is mainly occurring at rest. So that is why their problem is at rest. Classical is on exercise. Treatment is same. We give nitrate to both the people. Nitrate. Plus we give CCB for vasodilation here. But CCB are contraindicated. CCB are used. Beta blocker are contraindicated in variant angina because they can cause vasoconstriction. Here they are used. CCB, beta blocker. Beta blocker decrease the heart rate, so heart will be not overburdened. It will pump slower. It will be beneficial. So that's why beta blocker, nitrate, CCB plus antiplatelet drugs like aspirin, because there's a high risk of thromboembolism in a coronary artery disease due to narrow lumen, turbulent flow, injury to the vessel. So that's why we should give the aspirin to prevent embolism in future, thrombosis and embolism. Now let's see, this I've discussed already. So what is the classical one? Remember, classical basically vessel is narrow. So when there's the exercise, it causes increased heart rate, sympathetic. As the heart rate increase, oxygen demand increase, which causes the pain. So beta blocker decrease the heart rate, decrease the oxygen demand, and they are very beneficial, very beneficial. Now, remember, if the pain is relieved within 10 minutes, it is called a stable angina. We will advise to get a TMT, treadmill test. If the pain is more than 15 minutes and not relieved and worsening, then it is unstable angina. It's an emergency. Bring to hospital. If you say, don't worry, keep sleeping, he might sleep permanently. So it need to be brought to the hospital. So if pain is not relieving more than 15 minutes, then it could be our yes MI also. That's why we need to bring to hospital. So what is unstable means? The pain is not relieved, is unstable. Pain is relieved, is stable. So what are the criteria? Criteria. बता दो criteria. Criteria is very simple. It is our yes relief or not relief in how much time. Okay. Now we discuss the screening test for CAD. So what we are seeing, the screening test for CAD. First is it is our stable angina. It is what thing? It is stable angina, TMT or drug stress test. What is TMT? We ask the patient to run on the treadmill and we check the yes our ECG. If there is a coronary artery disease on doing exercise, there would be ECG changes. But if there is person not willing to run or not in capacity to run, we can do the drug stress test. We give dobutamine through beta 1 receptor. It causes tachycardia, and again ECG changes will be there. So what are the two methods of doing the stress test? Either you do treadmill TMT, or if TMT not possible, go for drug stress test. What test? Drug stress test. Okay. Now what is the method of doing it? It's called as Bruce protocol. So ये आ सकता है एग्जाम में और आया भी था. Bruce protocol is done for, answer is cardiac stress test TMT. So TMT is Bruce protocol. Now what is the ECG changes? So first remember, in Duke score, which is for stress testing, we check the Duke score. What score we are checking? Duke score. There is ST depression. What is there? ST depression is there more than 1 millimeter in 2 or more leads. So how many leads? 2 or more than 2 leads for more than 80 millisecond, which is 0.08 second or 2 boxes. So remember, अगर 2 boxes में दो बॉक्स से ज्यादा क्या आ रहा है आपका डिप्रेशन आ रहा है जो चल रहा है, और कब तक चल रहा है ये 80 मिलीसेकंड, और कितना है एटलीस्ट 1 mm, एटलीस्ट 1 mm is called as our yes positive treadmill test. And what is the score we use? Duke score is used for our calculation in stress test. So Duke score is for CAD, and that is the case. Now in case the test is positive, CAD is present, we go for angiography. So angiography first or TMT first? What we should do? Tell me. Anyone? Chalo, let's revise it. I have chest pain. I have chest pain, left side, radiate. Okay. First is, what do you ask? Ask me when started. That is time. And how. Now, if he say started, okay, 2 minutes back. Now pain is not there. This is our stable angina. If pain is more than 15 minutes, it is unstable. Okay, so he say started 2 minutes back, now pain is gone, or 5 minutes back, pain is gone. If pain is more than 15 minutes, is unstable. How? At rest is what? Variant, Prince metal. Okay. Next, yes, on exercise, walking, or saw result of child, or saw chat of girlfriend boyfriend with best friend. तो ये कौन सा वाला है? So if a person read chat of the girlfriend boyfriend with their best friend, तो कौन सा वाला चेस्ट पेन होगा? कौन सा वाला होगा? This is our classical. तो उसकी क्लास लगा दी उसकी क्लास लगानी, ठीक है. चलो, डन. ओके, व्हाट इज द ट्रीटमेंट? नाइट्रेट्स, CCB. Here also nitrate, beta blocker, and tell him to go for stress test. Done. This flow chart give you one question for sure. So classical. Very good. You are right, Dr. Thiraj Raj, Dr. Rajvansh. And what you will get, if you see the chat, you get the classical angina. Okay, what you will give to them? उन्हें क्या देना चाहिए? What we should give to them? उन्हें इनाम में क्या दिया जाए? What you should give them? उन्हें क्या दिया जाए? हमें तो पेन मिला. What we should give them? क्या करना चाहिए? क्या करें? Yes, you should let them marry. इनकी शादी करा दो and then let them suffer. ठीक है, क्लियर है? तो कभी आपके पार्टनर ने कुछ गलत किया, चीट किया, डोंट टेक रिवेंज, लेट देम मैरी दैट पर्सन एंड यू एंजॉय, गिव योर बेस्ट विशेस. यू नो आफ्टर मैरिज पंगा तो होगा ही, है कि नहीं? बिकॉज नथिंग इज परफेक्ट इन द लाइफ. सो दैट इज द यस एडवाइस. ओके, चलो, आर यू क्लियर विद एवरीथिंग बच्चा लोग? See, I always think out of the box, okay? That is my idea, okay? So I always think not in the box, out of the box. That is what the idea is, okay? Clear? So, सबसे बढ़िया solution ये है. The best punishment is sometime giving them, like you're pulling the rope and someone is trying to pull you down, leave the rope, they will fall down. So that's why sometime leaving the things go are the best solution, okay? Chalo, let's continue back. This is angiography. In angiography, this is RCA. Can you see that? This is not RCB, please. It's not RCB. It's RCA. Okay. No RCB. It's RCA. This is our LAD. This is circumflex. And this is our LCA. This is our LCA. Okay. RCB बोलते कई लोगों को angina हो जाता है. Okay. So lots of people get angina listening to word RCB, especially RCB fans और विराट कोहली फैंस. पर क्या करें भाई, जब किस्मत में लिखे हों डैश तो कहां से मिलेंगे पकोड़े. सो इसीलिए उनकी किस्मत में क्या है, कुछ लिखा हुआ है, तभी उनको पकोड़े नहीं मिलते, कुछ और ही मिलते हैं. ठीक है, चलो. सो लेट्स कंटिन्यू. अदरवाइज पीपल गेट टी विद समोसा विद पकोड़ा, उनको कुछ और ही मिलता रहता है. चलो, लेट्स कंटिन्यू. ड्यूक स्कोर ये हो गया हमारा. नाउ ट्रीटमेंट. सो ट्रीटमेंट ऑफ CAD कंफर्म हो गया. CAD है. रिमेंबर, लाइफस्टाइल मॉडिफिकेशन, बिकम लाइक मोदी जी, बी लाइक मोदी जी, नो अल्कोहल, नो दिस. देन BP, कंट्रोल BP, शुगर, वेट कंट्रोल, एक्सेट्रा. सो लाइफस्टाइल, अल्कोहल, नो अल्कोहल, बहुत पी लिया तुमने, अब दवाई पियो. नो अल्कोहल, स्मोकिंग, ठीक है, नो toxic relationship, nothing. Okay. Medical management. So what is medical management? Okay. Okay. So this is our, yes, enoxaparin we can give. So aspirin, clopidogrel, low molecular weight heparin, and what? Enoxaparin. Enoxaparin is there. Enoxaparin. Okay. Okay. Now question. What is also we give? The GP2B and 3A blocker, which is monoclonal antibody called as abiximab, beta blocker, statins for dyslipidemia. But most effective treatment is PCI or CABG in few cases. Now, what is PCI? Percutaneous intervention, where we dilate the stenosis vessel and you inflate the balloon and then place the stent. So the stent is placed, this is the case. So you put the guide wire and then you see, can you see this yellow structure? This is your atherosclerosis. Can you see yellow? Atherosclerosis, yellow, dirty fellow, very dirty fellow. So we put a guide wire with a balloon, inflate and dilate the vessel and leave the stent. So this structure is the stent and this stent will prevent the reocclusion. Okay. Next is stent could be, yes, this is called as balloon angioplasty and stenting. What is it called as? Balloon angioplasty and stenting. So balloon angioplasty and stenting. Okay. Stent could be metallic or non-metallic, or it could be what? Drug eluting stents. What they do? So these one release small amounts of what? Drugs which are mainly preventing re-occlusion. So that is why there is a very high risk of our re-occlusion, infarction in the patient with CAD sometime. That's why we need to put a drug eluting stent. Few cases we can go for CABG. Now what is CABG? It is coronary artery bypass grafting. Coronary artery bypass grafting. What is that? We take a graft, that is another vessel, and you connect it with the coronary artery which is patent with the aorta. So blood from aorta will go to that area rather than the coronary blocked artery. So let's say in this diagram, this LED, so this LED is blocked. Can you see this? This LED is blocked. If this LED is blocked, the blood is not coming. If the blood is not coming, obviously we need to find a solution. You cannot put a stent in this case because again multiple indications are there. So what you do is you connect through the graft and this will bring the blood. So that is called as CABG. Okay. Now it's a major surgery. Why? To access and connect, we cannot do it through the percutaneous route, which is again in the case of angioplasty, it is percutaneous. We can go through the skin and do it. It is a major surgery called as open heart surgery. So open heart surgery. Now what do we do in the case of our open heart surgery? Tell me. So what are we going to do? First and the foremost thing, Radu, we are going to use a graft. Which graft? Best is Lima. Lima is left internal mammillary artery. So left internal mammillary artery called as Lima, or internal thoracic artery, that is ITA. What is that? Left internal, yes, or internal thoracic. And we can use saphenous vein also. Best is our Lima. Now indication, triple vessel disease. If three vessels are blocked, it is called as triple vessel disease. In triple vessel, what do you do? We do CABG. Stent cannot be given in all three. Then if it's a double vessel one, what condition? Double vessel. Again, we can do the CABG. Or if there is a left main coronary artery disease, again we go for CABG. Now we'll discuss very important ACS, that is acute coronary syndrome. Just 1 minute, I'll get my water bottle and come. My water is finished. Just one. Okay, let's continue. आ जाओ भाई. Let's start, let's do, let's study. Now comes the question ACS, acute coronary syndrome. Acute coronary syndrome. Basically, it is a medical emergency. Pain is more than 15 minutes, not relieved, and it is worsening, called as crescendo, means increasing, rising. So rising is called as crescendo. So it could be MI or unstable angina. So what is MI? Infarction. Unstable angina, infarction is not there, but the pain is not stopping. So remember, what is death of the tissue? MI. What is pain not stopping? It is unstable angina. That is why we use a term called as acute coronary syndrome, in which it could be MI or it could be unstable angina in this case. So are you clear now? Clear? Yeah. See, you can do the same. What I do is I always use a pen and paper and give the summary. You remember? So all these summaries I give about the diseases, it is very, very, very effective and important. I tell them, everyone, whenever I write a summary, use my summary and follow them. These summaries are very effective, and that is the case. Right now, I don't have time to do this because I'm working 14 to 15 hours. I take offline session, I take online session, then I have recordings also, I have PG classes also. I'm working 14-15 hours. अब इससे ज़्यादा मैं क्या करूँ यार, मतलब it's not possible for me. Okay. देखो मैजिक, हो जा भाई. Okay, done. Okay. Now it's okay. Yeah. Okay. Now it's a good idea. Okay. Pen paper is the best way to revise. Pen and paper is the best way. If you revise with pen, it is best. Okay. Magic कर रहा था पर हुआ नहीं, कोई बात नहीं. My eyes look so blue because of reflection of light. Yes, so actually it has UV filter. My glasses have UV filter, so that's why it protect my eyes. Chalo. Please come back, join in. Okay. Now what is MI? MI is myocardial infarction. It's a death of the cardiac tissue due to prolonged ischemia. Now it causes coagulative necrosis, okay, which then also cause inflammatory condition. That's why pain is worsening. Reason? Ischemia and MI are different. Ischemia is lack of blood, but MI is the death of the tissue. That's why there's now inflammatory changes, and that's why the pain doesn't relieve. Pain will worsen. Also, there is, what else is there? Right. Also, there is, yes, the content of the cell will leak out. Which content? Potassium, enzyme, protein, etc. As they leak out, it causes ECG changes, arrhythmia, plus the enzyme and protein act as biomarkers. What do they act as? They act as our biomarkers. Which markers? Biomarkers. Treatment is obviously we give MONA, ECG and biomarkers. So the treatment is ECG biomarker, like morphine. Morphine is for pain relief. Morphine is for pain relief. Oxygen is obviously for oxygen supply, and nitrates are basically to decrease the BP, and they also help in vasodilation. So therefore vasodilation. But remember, contraindicated in inferior wall MI. Do not use vasodilator. In which condition? Inferior wall MI. So inferior wall MI, plus we give aspirin 300 to 600 milligram. It is chewed. It is not swallowed. It should be chewed and then swallow after proper chewing. So let's revise. What is MONA is? MONA is morphine, oxygen, nitrate, aspirin. Don't use nitroglycerin in patients of inferior wall MI. There we give inotropes. There we give inotropes. You can write here. So inferior wall MI, inotropes. Okay, let's continue. Now biomarkers for MI. First to rise is HFABP, which is heart fatty acid binding protein. It can rise within, so in what time? It rises within 30 minutes, but it is not very specific, so not used in most hospitals. Second to rise is myoglobin, but it's not specific. That's why again not used. So these two are just academic questions, not clinical practice. most sensitivity, most specific are our troponins. In that also troponin I is best for MI compared to troponin T, but T stay longer. So that is why it is the one. It is used if you are checking after, let's say 2 weeks, it will be the T. But if you are checking right now, I gives you better value. Okay. Yeah, there is a wavy fiber in this case. You can write wavy fiber. Now clear? Okay, Vivian? Yes. So when you do yes, autopsy and do the examination, you see wavy fibers. So, next question is clear? Okay. Now next question. If there is a reinfarction, we can use CKMB. Okay, we'll discuss now. Normally, if the heart is normal, LDH2 is more than LDH1. But after MI, the LDH1 leaks out. So what leaks out? LDH1 leaks out. As it leaks out, it will enter the blood. And now what is more in the blood? LDH1 is more. And that's why flip occurs. So in MI, 1 is more. MI, 1 is more. 100% exam question. Okay. Now, earlier, what was the method we can use? CKMB. Now it is used mainly for reinfarction. Reason? Troponin is already elevated. We can use CKMB to indicate a reinfarction. So that's why what is the substance used for reinfarction? It is CKMB. What is best for earliest? Earliest is given by heart fatty acid binding protein. New marker copeptin, new marker copeptin, and what is most sensitive specific? It is troponin I, and long acting T. T stay longest. Next question, if ECG, biomarker, anything is present, MI. If they are negative, it is unstable angina. So remember the rule, any one positive ECG or biomarker MI, both negative, unstable angina, both negative, unstable angina. Now we see the ECG changes in MI. So what are the changes? Remember, first change is tall T wave. So for the first tall T wave, this is a T wave now. So this T wave become much bigger, and as it goes up, the ST also start going up, and that cause the classical tombstone appearance. So mnemonic is also tombstone. T for T wave, ST for ST elevation. So tombstone, मर जाएगा patient, so you will put a tombstone on his dead body grave. So that's why same way graveyard में क्या लगाते हैं? On the grave head we put the tombstone. So tombstone appearance is seen. Okay. What is the first change? T, tall T wave. Then there is ST elevation. ST elevation. Next is what is ST elevation? Also called as Paddy sign. Paddy. So क्या बोलते हैं? Paddy करनी है Paddy. So क्या है? परदेसी परदेसी चला गया. So Paddies go up, upper. So upper elevation is Paddy sign. Upper is Paddy sign. Now third change is T wave inversion. So this is the third change. So what are the changes in acute ST elevated MI? There is a tall T wave along with the ST elevation. Then T wave start to invert. So what start to invert? T wave. It become biphasic, up and down. Then ST elevation improve, but T is inverted. Last change is only pathological Q wave. So the last change, but the permanent change is pathological Q wave. So remember, Q wave can persist all life. So what can persist all life? Q wave can persist all life in the patient. Are you clear? So that's why it is not the main. Okay. So that is why acute ke liye we depend more on tall T wave, ST elevation. What is the pathological one? It is our Q wave. It is our Q wave. Okay. So if there is a pathological Q wave but no ST and no, this is a old infarct. It's a old infarct. Only Q wave, old infarct. Q wave along with the ST and T, acute infarct. Next question, what persists all life? I told you Q wave persists all life. Others become normal. Now remember, inferior wall MI, there will be ST elevation in 2-3 AVF. 2-3 AVF elevation, and there will be a depression in AVL1, which are called as reciprocal leads. So remember, who's the reciprocal leads? For inferior, corresponding leads are 2-3 AVF. and the reciprocal are AVL and 1. Vice versa. For lateral wall infarct, who's the corresponding leads? Corresponding for lateral is AVL1 and reciprocal are 2, 3F, which show depression. So elevation in corresponding, remember the rule, elevation in corresponding and depression in reciprocal. Elevation corresponding, depression reciprocal. Inferior wall, who's the corresponding? 2, 3 AVF, reciprocal AVL1. Lateral wall, who's the corresponding? AVL1, reciprocal 2, 3 AVF. And anterior wall, V3, V4, reciprocal 7, 8, 9. 7, 8, 9, vice versa. Now remember, if it's a inferior wall MI, so remember, treatment of inferior wall MI is basically IV fluids, inotropes to increase the pumping. Remember, in inferior wall MI, we will not be dependent on what nitroglycerin, etc. We give IV fluids, inotropes. Nitroglycerin is contraindicated. Main is inotropic agents. Okay. Now we'll see the anterior wall MI. What do you see? The changes in V3, V4 and also to some extent in the V3, V4 and V1 also. This is anterior wall MI. It's an anterior wall MI. Anterolateral, we see V2 to V6, okay, and also there is a elevation in our which leads. This is lead 1 and L, AVL. So AVL and lead 1 is also showing elevation. So that means and also AVL and 1. This is our anterolateral. V1 doesn't show the elevation. So that's why it's not a extensive anterior wall. It's an anterolateral one. This inferior wall, you see ST depression in 1 and AVL. And we see, so that is showing depression. Elevation is in 2, 3 AVF. 2, 3 AVF. So this is a classical inferior wall MI. We'll take till 11:30. We'll finish once we reach page number 30 to 35. Now let's see. Management. If a person is having STEMI or non-STEMI, what is STEMI? ECG is showing ST elevation. Non-STEMI is no ST elevation is present. So what is absent? ST elevation is absent. Okay. But biomarkers are positive. So what is positive? Biomarkers are positive. So what is positive? Biomarkers. Biomarker. कौन सा word? Okay, I'll do this in the end. Okay, Dr. Rajvans, I'll do in the end so that I can do it with people comfortably relaxed. मुझे पहले खत्म कर लेना मेरे भाई, वरना बहुत pending हो जाएगा. So ECG, ST elevated, non-ST elevated. Okay, so what is there? Biomarker positive, but ECG is negative. So biomarker positive, ECG negative is called as non-STMI. Now, if it's a STEMI, that is ST elevated, MONA is given plus other drug, main is PCI. Immediately, if possible. Obviously, if it's a village, you cannot do. The door to balloon time is 90 minutes up to 120 minutes. So how much time you should put the balloon and inflate the balloon? Within 90 minutes from the door to the time of the insertion and inflation of balloon. That is called as door to balloon up to 120 minutes. If not possible, patient is very far, you cannot do it within 120 minutes, then we can do thrombolysis. Because thrombolysis, the best thing is what? It's just injection. Injection can be done even by a MBBS doctor. Like example, there is a medical officer or there is some PG first year. Can he do? Yes, he just need to take the consult of the whatever superior doctor and he can inject the TPA. TPA create the enzyme plasmin activity. Plasmin break the fibrin clot. So that's why it can restore the blood supply, but more powerful, more effective is PCI. So remember, PCI is superior to thrombolysis because PCI you are putting a stent and dilating is more faster, more beneficial. So PCI is superior, but problem, it need a OT, cath lab along with a trained cardiologists who can do it. That's why it is not done in all the condition, only selective cases, only selective cases. Now, next question. What is the TPA we use? Streptokinase, 1.5 million unit. What is the unit? 1.5 million unit. What is the duration? It's a slow infusion up to 30 to 60 minutes. 30 to 60 minutes. Over 30 to 60 minutes. Alteplase, we give bolus dose 15. Then we give 0.75 mg per kg as the next dose. Okay. Tenecteplase is single dose. That's why nowadays hospitals costly advise give single dose of tenecteplase if PCI not possible. If PCI possible, go for PCI, otherwise do. Now remember the time for injecting called as door to needle time. It's called as door to needle time. This is 30 minutes up to 60. Remember 30 up to 60. Balloon is 90 up to 120. 90 up to 120. If no relief, then we go for rescue PCI. What does rescue mean? Save the person. So that's why rescue is we are trying to save as much tissue as possible. So now we can do it after 12 hours also. So after 12 hours, what we can do? This. So that's why remember rescue means we are doing it as an elective procedure. It's not an emergency, elective procedure. That is elective. We plan and do it. So we will look for the indication and do. So what is immediate PCI? Immediate PCI in STEMI if it is possible within 120 minutes. If not possible STEMI, acute MI, you will do thrombolysis. With what agent? Best is tenecteplase, single dose. So it's not a problem. Streptokinase we give by slow rate 30 till 60 minutes. So very slow rate we are giving. Finally, if it is non-STEMI or unstable angina, give Mona. Give Mona is sufficient. Also we use what drug? Clopidogrel, beta blocker, abeximab. So they can be used in the patient. They can be used in the patient, abeximab, etc. But remember the rule. What is the rule? Rule is no thrombolysis. No thrombolysis is done in STEMI. ये last year NEET PG इसका एग्जाम का क्वेश्चन था आपका, FMG एग्जाम का. NEET PG also is asked multiple times. So that is you don't do. So where do you do thrombolysis? Yes, thrombolysis is done in STEMI. If no time available for this, we can do thrombolysis. But remember, no thrombolysis in patient of non-STEMI or unstable angina. What we can do? Delayed PCI. Remember, rescue PCI, STEMI after long time or not able to do it immediately, we do rescue PCI. Okay, not 2 hour, 3 hour. It's said to be after 12 hour, we can do rescue PCI. And what is delayed PCI? If no relief in non-STEMI, we go for delayed. So that is non-STEMI. So non-STEMI delayed. So what is the door to needle time? 30 up to 60 minutes. Pain more than 15 minutes is unstable angina or MI. ACS, what do you do? Mona, do ECG, biomarker. If it's a STEMI, immediate PCI is the treatment of choice within 90 to 120 minutes is called as balloon time. If not possible, no PCI, then inject streptokinase or tenecteplase. Door to needle time. What is the door needle time? So door needle time is 30 minutes. Upper limit is 60 minutes. If failed, we go for rescue PCI. If failed, we go for rescue PCI. What we go for? Rescue PCI. And no thrombolysis should be done in non-STEMI and unstable angina. We can give the drugs and wait for delayed PCI. Inferior wall, we give IV fluids, inotropic agent, PCI can be done, no nitroglycerin. So we'll do a basic idea about the heart failure. Then we will end the session. Tomorrow I'll do the heart failure and the coronary artery disease done, ECG done. So we are just left with half cardio and nephro and this kidney. It'll be done, don't worry. So let's start. Ventricles. So heart failure, when the ventricle fail to pump the blood, it's called failure. And if there's a decreased output BP, is called as cardiogenic shock. That is body not getting the blood. Also, as the heart can't pump, the blood accumulate behind the heart. That is called as congestion and causes edema. There are two kind of failure: systolic heart failure, diastolic heart failure. Diastolic is poor filling, can't fill the, and diastolic volume is reduced, which is the EDV, filling volume. And pumping failure, mainly the stroke volume decrease, heart can't pump sufficiently. This is called as systolic failure. It is seen in MI, massive MI affecting all the layer, called as transmural MI. Okay. Then arrhythmia like VFib can cause, or cardiac arrest can cause systolic failure. Myocarditis, dilated cardiomyopathy, obstruction to outflow like coarctation, aortic stenosis, HOCM. Again, ventricle fail to pump the blood. Drugs, septic shock, alcohol, very common. Alcohol can cause this, or doxorubicin, septic shock, so many things. So endotoxin of the bacteria suppress myocardium, or even trauma to the chest. So all of these causes pumping failure. Whereas diastolic is poor filling. What are the causes? Restrictive cardiomyopathy, heart can't stretch and fill. That is restrictive. Constrictive, heart is compressed, not able to again relax and fill. Or tamponade is compression over the heart, or some valvular lesion, less flow into the blood. So less blood flow to the heart. So all of these are diastolic failure. So systolic failure, diastolic failure. Now, this table you can skip. Just remember, in systolic failure, ejection fraction is low. Ejection fraction. In diastolic, ejection fraction is normal. That's why it is called as what? It is called as our heart failure with reduced ejection fraction, or REF. I'll give the red color. So systolic failure is REF, reduced ejection fraction. It is less. In diastolic failure, the problem is filling. So EDV is less EDV, but ejection fraction is preserved or normal. That's why it's called as preserved ejection fraction. It is normal. So one line summary: if ejection fraction decrease, it's a systolic failure and called as reduced ejection fraction, REF. If ejection fraction is normal, it is called as PEF. PEF is preserved ejection fraction. That's it. And if there is a systolic failure, you can get a cardiomegaly because heart can't pump, so it dilate. So dilated heart remodels, become abnormal shape, called as what? Our remodeling. And the CT ratio, cardiothoracic ratio, become more than 50%. I'll show it later. And if there is normal size, or hypertrophy, it is seen mostly in diastolic. What is the sound? S3 gallop. S3 gallop is seen in systolic failure. Loud S4, or yes, S4 gallop is seen in diastolic failure mainly. Treatment, inotropes. So the treatment, inotrope to increase the pumping. Contraindicated, beta blocker. What is contraindicated? Beta blockers are contraindicated. In case of diastolic, we need to correct the filling. Surgical intervention can be done like pericardectomy or valvular surgery, valvulectomy, or yes, valve replacement, valvuloplasty, and also beta blocker. Beta blocker decrease the heart rate, which increase the diastole and improve the filling by giving more time for blood to come. So let me give a summary, then I'll end the session. Tomorrow we'll do this failure, okay, and then we'll do the rheumatic fever, etc. And it'll take 1 hour. Cardiology will be over. Then remaining 2 or 3 hours, I'll do nephro and the respiration. Are you clear? So let me give a summary, then we end the class. What is the summary? Summary is systolic heart failure, HF, diastolic, HF. One word summary: poor pumping, poor filling. What is the hallmark here? Decrease EF. Here, normal EF. So also called as HF ref. Ref is reduced ejection. It is HF PEF. What is PEF is? Preserved ejection fraction. P is preserved. P is preserved. Are you clear? Okay. Then next question, less than 40%. Then what is here? Cardiomegaly and remodeling. Of ventricle. Here hypertrophy. Ventricular. And finally there is S3 gallop. There is S4 treatment. Inotropes. Here treatment beta blocker and surgery. Here inotropes, beta blocker, contraindicated. This table can give you one question for sure. Please don't forget it. I'll show you cardiomegaly now. So let's see cardiomegaly. See, I can teach without any PDF also, but again problem is time is less. If I write and teach, it will take long time. That's why I'm using this. So have a look at this. So this is your normal heart. See, the cardiothoracic ratio should be 50%. That is 0.5. Can you see? So this should be 0.5. Okay, heart. So that is why the heart is small. It is 0.5 size. What size? 0.5 is the value. 0.5. Okay. Next question. If there's a cardiomegaly, the ratio will become more than 0.5 in adult. Look at this. Tell me, what is the ratio here? Does it look smaller or bigger than this entire ratio? So that's why now it's bigger than thoracic ratio. So this is cardiomegaly. Can you see? It's more than 0.5. So this is cardiomegaly. Cardiomegaly. So let's end the session. I'm ending it. Okay. Have your food, dinner, relax. And tomorrow we will continue. Time I'll update. It's 3 o'clock or 4 o'clock. I'll update soon. Okay. Chalo. So let's end the session. Thank you everyone for watching. Yes, keep attending, keep learning. I am covering everything. I am not skipping anything. If you do this PDF, 100% you are going to, yes, succeed in the exam. That is my promise, because I have experience of NEET PG, INI-CT, FMG exam. I know their question. I'm teaching for almost 16 years. So 16 years of experience is very big experience. Okay, chalo. Take care. Bye bye. Good night. Good night.